question. So anyway, it's a really a pleasure to be here this morning, and I've worked for I wasn't sure how many years, but I think well over 5 years now in presenting dermatology sessions. Thanks very much for your kind introduction, Helen. I basically am a little bit of a maverick because I sort of work for various people. So I have an NHS clinical role, which is actually in Birmingham. So there might be some people from Birmingham here. So I work for Birmingham and Solihull, CCG, My Health Care Federation, My SDS Healthcare. With a new dermatology service, which has been fascinating because we've been developing a virtual service. I work in skin cancer screening as well as a private role, which is really interesting because I do lots of dermoscopy. So I have 6 clinical days a month shared between the 2 services. I work for the National Eczema Society every Monday afternoon on their national helpline. So that's fascinating because I talk to people from, I always say postcode Z to postcode J. So special prize if you know where postcode Z is. It's in the Shetland Isles and Jersey. So the whole country. And then I also have my own training company as well. So I do training mainly for other people, not that much for myself, and I'm actively involved in dermatology nationally. So I'm a member of the British Association of Dermatologists, a member of the British Nursing Dermatology Group, and I'm really pleased and really proud to say that I've just been elected as the first non-GP member to represent other primary healthcare professionals on the Primary Care Dermatology Society. So if you really want an excellent resource for primary care dermatology, which really spans the needs of GPs, pharmacists, nurses, podiatrists, anyone who works in primary care, you can do no better than look at that resource for dermatology. So, you know, this session I put for you together is a brand new session. It was a little bit challenging because it's sort of dermatology in a morning and there's a lot to cover. I could actually do a day on each of these topics, believe it or not. So what I am going to do...
Julie, can you just remind me of that resource? I was also missed it. What was the resource you thought that would be good?
Yes, pcds.org.uk, Primary Care Dermatology Society. So what I'm going to do this morning for the first hour is do a really good overview, hopefully, of the common skin conditions you'll see. So what the 4 conditions I picked, which are really the top 4, acne, eczema, psoriasis, and rosacea. I'm then going to add in a little bit of recognizing skin infections, fairly brief. And then I'm also going to have a little brief presentation at the end about COVID-19 skin symptoms, because what's really interesting is that skin symptoms are becoming quite significant, particularly with all the variants of COVID, but particularly in younger people who don't actually exhibit any other COVID symptoms. So we now say 8% of people with COVID have skin symptoms. So I think it's quite interesting that you're just aware of how it can present, and it just alerts you to maybe getting people to go for a test, even if they don't have, you know, cough, sore throat, and loss of taste and smell. So I hope that will be really, really interesting, and that knowledge is really gathering. So that's me. And before we start, and I think you've already started voting, which is fantastic, but this presentation is also going to be highly interactive. After coffee, very interactive, but I've still got 5 interactive stops within the first hour. So really just to keep you really engaged, and just to hope that, you know, I'm really meeting your learning needs as we go. So the first question before I share the learning objectives I've set for you is literally how confident, oh gosh, there's a typo there. Oh, where's that nabbing? It's meant to be managing. I'm so sorry. I thought I'd spell checked this.
I was wondering. I translated.
Sorry, that's just, anyway, managing. Nabbing is not a word. So how confident do you feel about managing patients with dermatology conditions? Remind me to get someone to proofread my slides next time. Anyway, it's caused a bit of a laugh, I'm sure. So we're talking about managing. So it's all about how you feel about confidence. If you just can all vote, there's no right or wrong answer. I'm just trying to gauge where you are, really. The votes are going up. I'll give you a little time. As I say, without a sponsor slot, we're a little bit more relaxed this morning, so we can give you a bit more time to answer. Yeah, so I think the votes are coming in. I don't know if people haven't voted or don't want to vote, of course you don't have to, but it's only just so we can get a gauge. So it's quite interesting, isn't it? It's interesting comparing it to the triangle Helen showed, from the novice to the expert as well, and maybe this sort of reflects that as well in terms of your learning.
I think some people are confident with some skin conditions, so that's interesting. And there are a lot of skin conditions out there.
There are
things in the chat, Julie, that people were interested. So
yes,
at the end of the session, I will scroll up and just check that. Oh, all right. Yeah, I mean, in response to my question, what do you see? I mean, Sally says patients often ask at the end of medication review, kind of by the way, someone acne, eczema, urticaria, psoriasis, eczema from Uma. Helen says when to try without antibiotics in rosacea, worrying things to look for, and there's something else about red flags in there. Erica says skin lesions, a session on differentiating benign from potentially malignant lesions would be helpful.
Yes, well, let's hold that thought, because I have a super session on that, and I'm passionate about teaching benign skin lesion recognition before skin cancer recognition, because certainly from my skin cancer role, and I examine full bodies all the time, if you can recognize normal, the abnormal actually jumps out at you often. So we hold that thought for a session in the future. Unfortunately, I can't possibly fit skin lesions into this one.
You're doing very well. And then Uma also says eczema, psoriasis, and difficulty of remote consultations, which I know you're going to cover.
Yeah, so it seems like I am fitting the bill for you all. I haven't got specific sessions on urticaria, and urticaria can sometimes be seen with eczema. Again, you know, all these topics are quite huge, but hopefully, you know, at the end, when you evaluate, we might be able to do sessions in the future. So
when to use antibiotics for rosacea. Anyway, I'll stop reading and we'll give it.
Yeah, actually the antibiotics for rosacea is a really, really interesting point, because I'm actually going to try and encourage you not to use topical antibiotics. And we're very aware, all of us, about antibiotic stewardship. And I do think after COVID, that's going to be the next big thing in healthcare. There's going to be a real exploration of antibiotic overuse. And in fact, I live in Oxford, and interesting news is that there's been a donation of 100 million to the team who developed the AstraZeneca jab for the future, to actually develop strategies in antibiotic resistance. So it's a big thing, and it's a huge thing for all of us. So great. So actually, I think we've got quite a nice range really between that. So hopefully something for everyone. So here's another question for you. And again, I think Helen's already said quite a few things, but do you just want to quickly type, you know, what do you really want to get out from this session? When you enrolled for a dermatology session, did you think, oh golly, you know, I really want to know how to manage eczema in children, or I'm not very familiar with psoriasis, or I just want to understand more about prescribing topical steroids. So that's just off the top of my head. So if you just do a type and just you know, literally top of your head, so that's just useful, and we can explore this. So we've got general update, managing skin conditions virtually, which is very, very key. And I certainly got experience in that now. Any other comments? As I say, general update as well. They're all coming on the screen. Identifying, managing, we'll do that. Topical treatments, yes. Oh, really pleased to hear you mentioning tacrolimus. The TCIs are a really important treatment in eczema, and very, very underprescribed in primary care. Stopping antibiotics, reminder of best practice, absolutely. How to differentiate between different skin conditions over phone consultations. Tricky, you do need images as well, but useful to talk about that. Great. That's really nice, isn't it? Just to see what people want. And that's great, because that sort of dovetails into what Helen said about collecting from you the various conditions. Okay, thank you very much. Right, we really will get started now. So I'm hoping by the end of this session, you'll have an updated evidence-based overview on managing chronic inflammatory skin conditions. So we're going to focus on this top 4. I'm hoping that you will also have a little bit of improved recognition of skin infections and also COVID-19 skin presentations. And I'm hoping you'll be more familiar with dermatology treatment pathways and dermatology QIP. Obviously, quality in prescribing practice. And I know there's a stray U there, by the way. I think there used to be a U there, but it is QIP now, or QIP prescribe. So QIPPPRESC. So we'll have a look at some of the QIPs for dermatology as well within this, because I was asked to do that specifically. I, as somebody who teaches, I'm really passionate about when I teach that it's got to be relevant to your clinical practice. And in that way, I like to think I can help you actually improve clinical confidence, because I think if you have a very dry lecture and you can't relate it to what you're doing in practice, the teaching is interesting, but it doesn't become useful. So hopefully my sessions are very practical. They are referenced and they are scientific, but they are very much geared to practice. So that's the name of the game in my view in terms of this session, particularly with, a short time. As I say, I could do each of these topics in a whole day. Just to acknowledge that I use images. Again, there's the PCDS email for you there, and also from another wonderful resource called DermNet New Zealand. So both these organisations have given me personal permission to use images for teaching, but I'm not allowed to reproduce them. So just to ask that you don't take images of the clinical images I show. I know people quite like taking an image on their phone when they listen to online talks. So you're very welcome to take images of any of the non-clinical ones. But as I say, I just don't have permission. So if you could respect that, be really grateful. Thank you. So let's go straight into the top 10 dermatology conditions seen in primary care. Now, I'm hoping that this will be quite familiar to you, because I'm sure this is what you're seeing yourself. But I just thought this was a really useful list, just picking out the actual percentages in our population. And it's quite startling how much dermatology there is around, or maybe not. So as you can see, acne is very universal. And for a lot of people, it's mild and people can manage it with over-the-counter. Indeed, there are a lot of very good over-the-counter preparations for acne. It's probably best served with OTC, but 15% it is moderate to severe and does need intervention. We know with atopic eczema, it's very common in children, but did you know, along with other types of eczema as well as atopic, and often with an atopic background, we are looking at 10% of adults, and particularly risen prevalence in the over 60s. And people think of it sometimes as a childhood condition. AK, which we're not covering today, or the benign skin lesions, are very common, particularly in sun-damaged skin. And AK, 2% of those can actually transpose into squamous skin cancer. And also we do know that basal skin cancer is common, and indeed melanoma is one of the fastest rising cancers in the UK. And benign skin lesions are very common. And of course, when people are checking their skin, they get really worried. They say, I've got this large brown mole that's grown over the years. It's raised, it's uneven. And actually, for people over 40, that's often a benign skin lesion called a seborrheic keratosis, and people get very worried. So as I say, recognizing the benign is actually as important, indeed from the starting point, more important than skin cancer in lots of ways, although I'm not dismissing, it's really important to recognize skin cancer, but reassurance on the normal is important. Contact dermatitis actually occupies 80% of all occupational skin disease, so really high. And then dry skin and itch in older people, everybody over 60 years is susceptible to itchy dry skin, which can move into a form of eczema. Psoriasis 2% and rosacea 1.6 in 1,000. Seborrheic dermatitis, another type of eczema, affects 5 in every 100 people because it's a physiological reaction to the melisma furfur, which is a yeast. And skin infections, actually the most common skin problem that presents in all areas of primary care. And then plus we have the COVID statistic, 8.8 of people actually have skin signs. So I think there's a lot to get through. There's a lot of dermatology. So just to start really with how you assess and you plan, and particularly focusing in a digital environment. So I'm just going to talk for a little bit about what I do. I work in Birmingham, and we have an advice and guidance part to our clinic where we give advice and guidance at the moment to GPs on on people who they refer to us. We ask the GPs for a full history, why they're referring, and also images. And sometimes this is the big problem with virtual dermatology. I believe you can't do a virtual dermatology consult without an image. And if you're following up a patient from advice and guidance, you ideally need to try and do a video consult. Because as Helen said, she said to me, well, how do you manage dermatology? Because you've got to feel and touch the skin. And what I said is, it's really interesting because I really thought that. And in the beginning, I was finding it really frustrating, but actually I've been really pleasantly surprised. And certainly I think with the chronic inflammatory skin conditions such as eczema and psoriasis, even though you want to feel the skin yourself, of course you can't virtually, but you can ask the patient in quite a lot of detail how the skin feels. And also you can use assessment tools for that. And with children, it really is great. I mean, I have a little toy box with me when I speak to the children. So I'm often doing a consult through a rag doll or maybe a cuddly dog or something, because the children get quite nervous about seeing healthcare professionals online, this sort of stranger. But as soon as you bring up a toy and you incorporate some play, and as I say, one girl was very scared of me, but not necessarily of me. I think she'd had a consultation with someone else and she just got scared of strangers on a screen. I just literally held up a rag doll and put myself to one side, and the whole consult was through the doll. And by the end, she was giggling and she thought it was really great that this doll had told her about her eczema. It was quite funny. And of course, the parents of babies and younger children and even older children, they're just really happy to just strip them off in front of you in their home on the camera, which is completely acceptable. And it's great with babies because I say, it would be good to see their skin, and indeed you can. So I think there are ways and means. I do think you need photographs. I think you can do it on the phone as long as you've got good images. The PCDS have a really, really good document which you can actually give your patients on how to take really good images. The key is to do a macro image. So you do literally get them to take an image of the whole limb and then a close-up of where the eczema is. The other key tip is with patient images is tell them, don't do selfies, because if you do a selfie and you lean down, particularly on a lower leg, it always becomes blurred. So always ask them if it's not a time where they should do selfies. They should actually get another family member to take images. I find it brilliant in acne, and actually pre-pandemic, I was always getting patients to take their own images of their face, chest and back, because it's the best way of assessing improvement with their skin. But obviously, you maybe have to ask, I think, the same kind of questions actually as when you're face to face. And we do ask about any previous skin treatments. Is this a new skin condition? Does it come and go? We talk about treatments. We always include OTC treatments and cosmetic treatments. And I think it's really, really important to ask about, have they bought anything online for their skin? My practice, I sort of got a jolt in my practice the other day because I attended a virtual conference on looking after dermatology and skin of color. And I was absolutely shocked because there was a presentation on skin bleaching, which is highly illegal, using things like hydroquinone and even mercury. It's really shocking, but also very potent topical steroids. And apparently in some cultures, the perception is for skin, as a socially cultural aspect of people wanting to have lighter skin for all sorts of reasons. I won't go into it. And I was shocked to hear that often from teenagers, particularly girls, because it can relate to marriage prospects, from teenage to old age, they would often be using these illegal preparations on their face in particular for life. So I'm just thinking of some of the people I've seen with very difficult facial dermatosis, particularly in my practice in Birmingham. And of course, apparently it's something that patients often hide from you, that they've been using illegal skin lightening products. So I just throw that out there because I have to now ask if I see somebody with very severe facial dermatitis. And I must admit, I hadn't thought of that before. So you're discussing all sorts of things about skin and expectations. And also it's really important to ask how the skin feels. I use more assessment tools, I think, virtually in a way, because you can ask patients to pre-fill them, but I did going back as well. But things like the poem is a really good tool for eczema, where you ask patients how their skin was over the last 7 days, and then you really get a feel of what the flare is. You can also ask about quality of life. And I think if you're sensing any feelings that the patient is depressed or anxious about their skin condition, it's really important to add in the PHQ-9. You give skin tips about how to get the best out of treatment and expectations. And I generally say you give a response time of when things are going to work. So as a general rule of thumb, 2 weeks to sort of get an acute flare of eczema under control, 4 weeks for psoriasis, and 2 months for acne rosacea. And that's really important because, you know, you're trying to encourage the patient with treatment. And then you book a review appointment for, you know, I mean, generally it depends. I say 8 weeks because I think that's realistic with workload at the moment, particularly with vaccinations. But ideally, again, I'd like to see patients with eczema in 2, psoriasis in 4, and acne rosacea in 8. And indeed, I am managing to do that. So that's just a little overview, and I do think it is possible. And if you want any more tips, you're welcome to contact me. So now move on. And we'll start talking about some of the actual conditions. So acne, again, for some of you, this is very much revision. Some of you are experts, as we've seen, some of you not so confident. So just literally a reminder about the etiology of acne. There are a lot of myths and misconceptions, but essentially acne is a disease of the sebaceous glands. So this is the sebaceous gland where the hair follicle resides. And basically what happens is at puberty, there is a surge, a hormonal surge, and particularly a surge of androgen, which is completely normal because it's part of puberty. And this leads to the sebaceous glands literally waking up, I always say, because the sebaceous glands are very, very active in the first 6 months of life. And indeed, that's the sole reason for cradle cap. That, you know, the greasy, scaly scalps that babies have. Interestingly enough, babies are never worried about cradle cap, but the mums and dads and carers always are. But as soon as a baby who has even has cradle cap starts itching and rubbing their scalp, and particularly if they have a family history of atopic eczema, that's eczema. Cradle cap is not itchy, it just sits there. It's just overproduction of grease, it doesn't cause itch. And again, then the sebaceous gland at 6 months, they literally close off because skin, they're not needed in childhood, and then they come into life at puberty. So what happens is you initially get greasy skin because you've got increased sebum due to these androgens. And then what happens as the grease builds up coming from the sebaceous glands, you actually get a closure of the duct. And once the ducts close, you can get colonization with an anaerobe. So bacteria, anaerobe bacteria colonize, and then you have infection within the sebaceous gland. And that then pushes against the cell walls, which are hypercornificated because of the blockage. And a lot of the mild treatments are actually really there to reduce the hypercornification and open up the duct so you don't get this closure. And then you can also get a lot of inflammation. If the inflammation gets really bad, it can really push out and it can actually rupture the sebaceous gland. And actually in that way, you can then get nodules and cysts, and that really then gives you your picture of severe acne, but we'll have a look at that. But I think it's really good to just explain what's actually going on. So obviously, clinically, you'll find greasy skin, we call it seborrhea, and the initial sort of closing of the duct is the comedone. So you can see blackheads and whiteheads. Sometimes they may be difficult to see in mild eczema, so acne, so you need to sort of stretch the skin. And interesting enough, the black in blackhead is not dirt. This is a real misconception. So people really want to squeeze out blackheads, but the black in blackhead actually actually is a melanin that's oxidated. So, and if people have got blackheads, they're much better to treat with a topical treatment and not squeeze. As soon as you get nails on the skin and you get squeezing and picking, this leads to scarring, and acne itself scars, and it's really important to prevent scarring. So you have inflamed lesions with papules, pustules and nodules, and scarring is often due to loss of tissue, atrophic scarring, so that's when you actually lose tissue, there's damage, or increased fibrous tissue where you get hypertrophic scarring. Now, the reason acne scars is because it's a disease that originates in the dermis, because the sebaceous gland is deep in the dermis. And the reason eczema generally doesn't scar unless it's scratched down to the dermis is because it's an epidermal disease. So more of that later with eczema, but acne can scar very easily, even from mild to moderate. Now, in darker skin types, and indeed it can happen in all skin types, pigmentation actually is a real problem. And a lot of people, we talk about this Fitzpatrick skin scale. So we would say say 1 is white, pale Celtic skin, going up to 6, which is black African skin. So if you look at that scale, and I would do this if I did the skin cancer talk, if you look at skin types 4, which would be Southeast Asia, into 5, which would be Asian, darker Asian or Afro-Caribbean, to 6, which would be African. These skin types, they're much more prone to pigmentation with acne, which actually can be more distressing than the acne itself. So it's really important to look at pigmentation and scarring. So again, a quick run through of how we would treat mild to moderate acne. And this is the updated evidence that, and I think, you see this, it was a big European group in 2016, followed up by the NICE clinical knowledge summaries. And the one great thing the PCDS can offer you is they have really good, completely evidence-based, up-to-date treatment pathways. They're really handy because they're just 2 sides of an A4 and they're pictorial, and they actually list all the treatments, and they have them for all 4 conditions I'm presenting today. So after this session, you can do no better than just revise the 4 treatment pathways of the PCDS, and they fit into NICE as well. So if you've just got comedones, blackheads, whiteheads, you need to really focus on a single agent. So we normally say a topical retinoid, adapalene, or plain benzoyl peroxide. Benzoyl peroxide, as you will know, it bleaches and it can make the skin quite sore and dry. So often you need to start with a lower percentage, say a 2.5, and then maybe move up. And these are available quite easily over the counter, actually, in various forms. Skinnerin is a second line, and this is a decornification agent that it actually comes from a grain, which is very good at sort of reopening the pores and stopping blackheads and whiteheads. But as soon as you start to develop papules and pustules and it becomes clinically significant, and that's about 15% of acne, you need to look at topical treatments. So the guidelines is very clear that the first line treatments should be a topical combination, and that's really, really important because we're not using anymore the single conformation. So we wouldn't necessarily use a Zineret or an Isotret as a single. We combine, and the combination, there's a choice really. Epiduo is probably the top choice because it's non-antibiotic, and again, we're trying to reduce antibiotic use in all dermatology conditions unless it's really necessary. So with normal sort of papules, perhaps a few pustules, I'd always go for Epiduo first. There are 2 strengths now, so you can move up the strength a bit, and the strength is on the benzoyl peroxide rather than the topical retinoid, but it's an excellent product topically and can work very well. But if you have lots of pustules, lots of sort of yellow pustules, you're probably better to add in a topical antibiotic. So Duac then would be, which is clindamycin with benzoyl peroxide. And then if you know, the other thought is that benzoyl peroxide is drying. And topical retinoid, again, is better for comedonal acne. You've also got the combination of Tretlin, which is topical retinoid, and clindamycin. One of the GPs I work with loves Tretlin. She uses it all the time. But we tend to go for Epiduo mainly first line. You can then, and then second, you can combine, you can then add in oral antibiotics with a topical antibiotic treatment. But the absolute rule is that if you use a topical with an antibiotic, which you should do as gold standard, the topical should not be antibiotic based. So we would always use an Epiduo generally if we bring in our first line tetracycline, that would be limacycline, or we may just use a plain retinoid or plain benzoyl peroxide. So really important that we don't use topical and oral antibiotics together, because we don't want to build up resistance. And remember, acne already has quite a lot of resistance problems. For instance, you know, erythromycin is 70% resistant now in P. acnes, and that's been from overuse in the past. So there is an eye kept on resistance levels, but limacycline, and second line obviously be doxycycline. We don't use Oxytet very much because of the other complications of several times a day eating with food and calcium deposits. But also with women, we would always try and add in what we call an anti-androgen combined oral contraceptive for women. In the past, it used to be Dianet, and Yasmin's an example of a really good anti-androgen contraceptive. But the Cochrane review in 2013 actually said a range of combined oral contraceptives were effective for acne. So you don't necessarily need to go for a specific brand, but you need to look at a sort of sliding scale. And certainly the progesterone antagonist oral contraceptions actually can make acne worse. So you wouldn't go for a mini pill or progesterone only contraception. So it's quite interesting. Obviously, there's an oral antibiotic guideline there, and you can see the resistance levels, so that it is still rising. So I think the key thing is that a lot of people with acne, they get stuck on their oral antibiotic for sometimes months, sometimes years. So I think what's really important is review, because actually often the acne has resolved or is a lot better. And I have this with my patients, and they say, well, I don't want to come off limacycline because my acne will come back. And what I say is, it's likely your acne is resolved. So we need to trial with you off oral antibiotics. And then I would add in Epiduo as a topical, so they've got something to tide them over. So I think it's really, really important, because I think there's too many people on acne who are perhaps left on oral antibiotics for far too long.
Questions, Julie?
Sorry, are there any questions?
A couple of questions if you wanted them now.
Yeah.
What is the best?
I was going to stop after the acne section, and
okay, good. That's fine.
But I just, in case, so I should have said that. Is that all right? Because it might.
Yeah, carry on, and I'll hold on to them.
We've almost finished the acne section, and then we'll stop after each section for questions. So severe acne. So this is what we've got to prevent. So basically, with acne treatment, another really important fact is that you've got to tell people not to treat the individual spot. I know it sounds mad. And Simon, who I work with in Birmingham, his lovely GP, he said acne treatment is anti-acne treatment. So when you treat the acne, you have to treat the whole area, the face, the chest, and the back. And the other tip is always ask, when somebody comes in with you with facial acne, always ask about the check in the chest and the back on assessment. So just two little tips here. As I say, it's hard to fit everything in because there's a lot to cover this morning. But with severe acne, there's referral to dermatology. And I think some of you will know about isotretinoin. I don't know if any of you are involved in any monitoring, but generally it's done from dermatology, although with COVID, things are changing, and actually most dermatology departments now, believe it or not, are monitoring isotretinoin virtually again. Because the thought is that they're only really coming into the hospital for a pregnancy test and their new prescription. And we're actually again effectively doing pregnancy tests online virtually. So we ask patients to have a fresh glass of urine and a new pregnancy test, and they actually dipstick in front of the prescribing doctor. I don't do the follow-ups because I can't prescribe isotretinoin, but the isotretinoin can be prescribed by GPs with a special interest only. So you can have it prescribed in secondary care if you have a protocol set up, which is very exciting. But it is a really difficult drug because the monitoring is really important. And I would go beyond that. I would say the pre-counselling, which I do, is so important. The most important thing is to tell people that if they start isotretinoin, they need to expect they will have an acne flare. So their face will become very red, often, not always, and their acne may even get worse. And there's, there has been controversy in the past, but there's been no link with isotretinoin and severe depression. And indeed, in the past, it was linked to suicide. And the thought was that acne is such a devastating condition. And if people are told this drug's going to, actually cure your acne, it's the one treatment that can cure acne, they're given so much hope, and then they take it and they're not counselled about this flare. They think, well, there's nothing more that can be done, and it's made it worse. So it's really, really important. And I sometimes think that's occasionally not emphasized enough in the nicest possible way. But as I say, it is tetragenic. It can affect liver and fasting lipids. So you'd always do baseline FTs and fasting lipids. And as I say, the awful thing is that it makes everything completely dry. So literally it almost sucks out all the grease from the skin. So you can get really sore skin, you can get eczema, you can get other headaches, muscle aches, it can affect sport, etc. But actually in 9 months, we started prescribing isotretinoin in June in the summer, and we've had 5 people who've gone completely through a course for 6 months with totally cleared acne at the end of it. Really interesting. So it is good. We haven't really had anybody in the last 6 months who has failed and come off isotretinoin, and we do assess for mood, and we haven't seen that. So we've seen a lot of positivity, but I think the counselling's everything, and the pharmacist could play a great role in that. So as I say, it does this is amazingly is a face. This is a girl just hiding her face. And I think, I think this goes without saying, so I'm not going to go through all this, but I think of all the conditions, all dermatology conditions have a huge impact on psychosocial well-being, but acne particularly, because acne often develops when a young person is actually really developing their own personality and wanting acceptance from peers. Whereas with eczema, sometimes children have had it from birth. They've often known no different. Psoriasis often develops a bit later in the teens and the 20s. So that's why acne can be so profound. And sometimes people with mild acne can be just as affected as people with severe acne. And we often see quite a lot of dysmorphic acne, where people look at their face and they've got mild acne, but they're just seeing a face full of spots, a little bit like body image distortion in anorexia. So it's really very, very key. So let's stop there and have a couple of acne questions before we move on to rosacea. Is that okay, Helen?
Yeah, that's fine. We've got a question from Mark saying, which topical preparations are best in pregnant patients? And obviously you avoid the isotretinoin.
Yes.
What do you recommend for pregnancy?
Well, I think there's no contraindication with the topicals. And again, I just need to double check on the SPFs because sometimes they can be different. But the thought is that you are just treating a small area and you haven't got absorption. But certainly the topical retinoids, I think there was some controversy about pregnancy and they shouldn't be used in pregnancy. But as far as I know, this has been thought that it's going to be a very small absorption. I think if you were concerned and you didn't want to use a retinoid, then you might be better to just stick with a plain benzoyl peroxide, or even look at some of the very good over-the-counter medications for a topical. I mean, I think there is the La Roche-Posay Effaclar Duo is really, really good because it contains nicotinamide, which is an anti-inflammatory, and also a salicylic acid. So again, that would be quite safe. So I agree. I do know there has been a little bit of controversy with retinoid in pregnancy, and I really do just need to go back and double check it. I haven't had a pregnant patient with acne actually, in the last 9 months. So I would go back and check it. But I think if you are in doubt, you might be better to look for one of the, you know, actually very effective. And I would say, I pick out La Roche-Posay because I would say it actually is almost as good as a prescribed topical medication for acne. The problem is it's quite expensive. It's about £20 for a pot because it's a tube, because it's cosmetic. But, you know, if you were feeling cautious, and I'll have a look in coffee and I'll get that answer for you. But, you know, you might want to not use a retinoid. So that's, you know, obviously up to your prescribing practice. But it's a really good question, and I will get a definite answer for you at coffee, if that's okay.
Okay, fantastic. Another a question from Sarah, well, a comment from Sarah, actually. I had a patient that had a reaction to Epiduo causing burning inflammation and dryness, severe flaking that caused the patient more distress. Have you come across that, Julie?
Yeah, I think it's the benzoyl peroxide, and I think it depends what strength you use. There are actually 2 strengths of Epiduo, and I don't know if possibly the newest strength, which is 2.5 benzoyl peroxide as opposed to 1%, can be a lot harsher. So possibly just check, but I'm sure you would have prescribed the lower dose. Again, I think you're right. I think benzoyl peroxide for some people can cause quite a lot of sensitivity. Other people cope quite well. So I would say, you know, if you feel people say that their skin's quite sensitive to products, and this is particularly actually if people have a combination of eczema and acne together. So if they have a history of eczema and you think they might flare with benzoyl peroxide because it dries the skin, so it's not so great for eczema, but it's good for acne. But of course, Epiduo's quite safe for eczema as well. I would say maybe start slowly, maybe every other night for 5 days, then move it up to every night, and then go to, you know, then move on to twice a day. But you know, generally, you know, once a day Epiduo is absolutely fine. And I generally say use it at night, but use old pillowcases, because we know that benzoyl peroxide can slightly bleach. So maybe just start slowly, and in between, I think benzoyl peroxide will suddenly dry the skin, and people with acne have been used to having quite greasy skin. So I'd say use a moisturizing lotion in between, which is unusual because often people with acne aren't used to moisturizing their face because of the grease, and then suddenly it dries out. So yes, it's unfortunate, and that's quite a nasty reaction, but I would say it's benzoyl peroxide based rather than retinoid based.
I can certainly confer in terms of the staining. I've got a son who's got bad acne, and he's got through an enormous number of towels that have been completely, yeah, you can tell when it's bad.
Yeah, it does stain, doesn't it? Yes. Old towels, old pillowcases, I'm afraid.
It's always my new towels, to be fair.
Old.
Eric,
towels then.
A question from Erica saying, what's the if using an oral antibiotic, what's the maximum time on one before you should review and consider stepping down? Is like 6 months or 12 months? And if there's no response to the antibiotic, should we be considering a referral? So that's a...
Yeah, absolutely. I mean, the gold standard would actually be to refer everybody in 8 weeks. I know that's not realistic, but certainly if somebody's had no response from limacycline after 6 months, and if there are women, and if you haven't added an oral contraception, I think you should refer to dermatology, because that probably is a clear indication for isotretinoin. That there's no point continuing really antibiotics after 6 months with no response at all. And limacycline, if it works, it's very good, you know, but I think also people just get, they just want to stay on it. They're just so scared if they come off it, the acne comes back. But often, you know, a 6 month, 9 month or year course of limacycline often will resolve acne. And you've just got to tell people, you know, they've got to try without an oral antibiotic, because otherwise, you know, I have heard of people being stuck on limacycline for 5 years plus, which is really slightly worrying. But, you know, I think you're very aware of antibiotic stewardship in your practice, and it might be a nice project to look at, actually, if you want to do a little project or audit with acne.
So you're saying if it hasn't responded with 6 and 9 months, then they should be referring for something else?
Yeah, I think 6 months really, because if limacycline is going to work, you know, you might give it a couple of courses, a couple of 8-week cycles, but I would say definitely I wouldn't carry on after 6 months if the acne isn't respond, even earlier, you know, even 4 months. I would say you need 8 weeks. You need to review every 8 weeks, and normally the first review of acne, if the acne is the same, you carry on with the same treatment for 8 weeks and then you reduce. If the acne's got worse, you maybe step up the treatment then. So you may even think of referral after 8 weeks. And if it's no better or no worse, you maybe carry on for another 8 weeks. So then if it's no better or no worse at 4 months, you might then think of referral. So that's sort of the rules that we would work with our clinic.
Okay, that's great.
Yeah.
So still on the subject of isotretinoin, how long does it, when it gets worse, before it gets better in terms of counselling our patients? What's the kind of time frame of all this?
It can be a flare for up to 4 weeks actually at the most, and then it generally settles. Sometimes people don't flare at all and it just clicks in, and other people may have a flare for only a few days. So I think the key thing with the counselling is you need to tell them to expect this isotretinoin flare and they need to work through it. And actually then you need to monitor, but normally it's probably on average, I would say a week, 2 weeks, but I say 4 weeks at the most. In fact, a friend of my daughter's, who she shares a house with at uni, actually had quite a nasty isotretinoin flare which lasted 6 weeks, so it was lucky I was able to support him with that. That was unusual though. I'd never seen one last that long before. It did happen to be James, who is her friend, but never mind. Typical.
So if you've got a question from Nisha, if you've got a patient on isotretinoin and they ask for recommendations on moisturizers to help with sore, dry skin, do you have any specific recommendations on that?
Yeah, I mean, definitely moisturize. I mean, what I say is I'm quite practical, that everything's going to dry out. And I had a boy referred to me the other day with isotretinoin dermatitis. So never had eczema, but his skin had dried out so badly. But his acne had responded really well, but he was more distressed about the eczema. So yeah, use emollients, often on the face. So lotion's better because with acne, because you know, but then sometimes if you've got isotretinoin, you dried out so much, you may need to move to a cream, you know, a sort of slightly oilier, lighter cream, and you know, just to say to use that twice a day with the dry, to prevent the drying out. With the lips, get people to use a lip salve, a really good quality. They probably have to buy that, but there are some you know, really good lip salves because they need to keep their lips will dry and crack soon. You can get nosebleeds because it dries out in the nose. So I say just get a little bit of Vaseline on a cotton pad and every morning just sort of go around your nostril with some moisturizer. And also eyes, it's a good idea to use some artificial teardrops, some hypermellows, you know, twice a day to keep your eyes from drying out. But everything will dry out. But then that's good because that means the isotretinoin's working. So you sort of have to balance it. And as I say, these patients are, these young people aren't very used to using moisturizers, particularly on their face. I mean, there's lots of nice lotions. There's which again, non-fragrant. So you could look at Diprobase has a lotion, Cetraban has a lotion. There's Ketophil, which is quite a nice lotion. And I would say just keep it simple, keep it bland, no fragrances. So yeah, do that.
Fantastic.
Okay.
A question from Nisha. Nisha asks, would you treat an adult, an older person, any differently from a teen, say a 40, 50-year-old? Is it exactly the same?
Yeah, I mean, to be honest, as I say, I could do acne in a day, and I definitely, in my other sessions, I could do it in an hour. And I haven't really mentioned about, it sounds like I'm teenage orientated, but what I should say is I see as much acne in 20 to 30-year-olds, particularly related with hormonal changes and sometimes PCOS. So just bear that in mind. 40, 50, unusual to see acne, although sometimes it can rumble on. So I think, you know, we haven't had anybody treated with isotretinoin in the last 9 months over, I would say, 28. So, but then there again, it's really frustrating because if I did my full talk on acne, I do a whole red flag and things, and there, you know, things like lithium, for instance, that can cause acne, and so there are other causes for acne in older age. But the thing is, it just depends if that person has always had acne. We generally say the lifespan of acne is generally about 6 to 8 years, and then it generally will burn out. But then we want to prevent the scarring, so we also need to treat. So if they're older with acne, it's a more unusual presentation. You know, I think just look at the history, and then maybe this might be somebody for referral actually. There might be other things going on, or look at other drugs they've got. I'm not sure. Yeah, that's a
okay. Thank you very much. I mean, another interesting question from Helen, who says that locally they use doxycycline, which is preferred over limacycline because of the cost. And I'm sure other people can recognize that. Is there a lot of difference between the two?
Well, first, the PCDS and also our practice, we prefer limacycline. I think there's more adherence because it's a once a day treatment. I don't think there's that much between the two, but doxycycline can sometimes make you photosensitive. So again, that can cause more facial redness maybe. So it's a bit between the two. It's difficult. I'm not sure of the exact cost differential. Interestingly enough, we're just about to move on to rosacea. We tend to prefer doxycycline for rosacea, but yes, you can use doxycycline. I think, but then just look at the adherence and think of photosensitive issues. And I think if they are similar, but as I say, it just tends to be the first line for acne within and within the guidance as well. But as I say, I don't think it's wrong because they are very similar. But anyway, but
that's great. I don't want to keep you because I know you've got a lot to go on.
Yes.
Quickly, just remind me the name of the expensive product and I'll type it in the chat because somebody was asking.
Yes, sorry, it feels like I'm promoting La Roche-Posay and I'm not at all. What I'm saying is that there are lots of OTC products for acne, but most of them are single. So for instance, you've got Clean and Clear, which is just salicylic acid. You've got your Clearasol range, which actually includes something called risosicol, which is an anti-inflammatory. You've got other products, but the La Roche-Posay one is quite nice because it's this combination. So it's
Can you spell it? I'm trying to type it.
Effaclarduo, EFFACLARDUO. But I think that, that I'm just thinking that EFFACLARDUO. Yeah.
EFFACLRDU.
Yeah, DUO. Sorry, duo. Sorry, I'm being confusing.
Okay, sorry, I got it.
But I think that the gold standard is a combined product. A combined topical product is better than a single product. Although for mild acne and comedonal, you perhaps would go for the benzoyl peroxide or the retinoid. And I think adapalene is going to be sold over the counter soon. I think it was going to be just before the pandemic and it was a bit delayed. So that's going to be a really good. I think with acne, there's quite a good armory for mild over the counter, and it's quite good to get to know your over the counter. And I should say, a lot of people like to select their own acne washes, and there's some really good products with the Neutrogena and Clean and Clear. I love going to a pharmacy and just perusing the acne shelf. I find it very interesting. Often take pictures and things. There's some good products, but unlike the other conditions, for instance, rosacea, there's very little over the counter. So straight on to rosacea. Get on. Yep, and as I say, I thought we just take a couple of rosacea questions because I have to say after coffee when we do the case studies, we're going to be looking at these conditions again, and I don't really want to shortchange anything. And as I say, at the moment, I think we'll be looking at just running a bit over 11, but I will push on. And as I say, remember, I'm literally slightly scratching the surface of these conditions. So rosacea is interesting because there's a lot of confusion. I think for me, the big confusion is it's often called acne rosacea, which is a descriptive term. So erase that from your minds and just call it rosacea, because rosacea is not acne and acne is not rosacea. Rosacea is all about vascular change and acne is all about the sebaceous gland and the overproduction of sebum causing all the problems. But saying that, a lot of people who've had acne in their teenage years, and maybe this lady in the 40s, 50s, it's possible, thinking of this question from before, has she got severe papular-pustular rosacea? Because it's called acne rosacea because you get the same skin symptoms as in papules and pustules. So that's a possibility. So people who've had bad acne as teenagers quite often develop rosacea, but it's a different skin condition. It's a curious skin condition. It's unlike acne. There's not a clear cause. It's really interesting. There are several theories. And of course, it only affects the face and generally the central face, and it causes redness, vascular dilatation. And as I say, you can get similar symptoms as acne, papules, pustules. So there are 4 types. You've got your erythrotelangiectatic, which is literally just redness and burning with no other skin symptoms. And again, you see central face, nose and chin. And then your papulopustular. So I am thinking of this lady we just discussed, where you really do get quite a scattering over the same facial area. Sorry, my fancy slide design isn't probably could be better for these pictures. And you literally, you know, it literally has an acne-like type, but it is still this vascular disease. And then more common in men, you get the rhinophyma, where you get the misshapen nose. And this can be really hard because people often think that, you know, this isn't rosacea, this is perhaps related to, you know, misusing alcohol, and it often isn't. And you can get patches here. And that's really hard because you get a lot of collagen bulking. The other lesser known type of rosacea is ocular, which is quite useful to point out. And this is where you get a lot of redness on the eyelid and even within the cornea. And you often get a lot of stinging and burning, sometimes even gritty eyes, but you often don't get, you know, you don't get sort of crusty yellow crusts as conjunctivitis, but sometimes it can link with conjunctivitis. And sometimes these patients are treated as, you know, chronic and ongoing conjunctivitis. So just be aware that, you know, ocular rosacea can occur by itself, but it's often connected with rosacea, and just have a look on the eyes. But I always say with eyes, you can never be too careful with eyes, and it can cause keratitis. So if people do have ocular rosacea, they should actually be referred to ophthalmics. If people are very distressed by rhinophyma, you may even need surgical intervention, and that would be plastics. There are various triggers. So I think there's lots of health education when people have rosacea. People find it very distressing, and often they can pinpoint their trigger, but often they're not so aware of it. So certainly, you know, you've got the weather, you've got sun is probably the biggest enemy to rosacea. So everybody with rosacea, whatever skin color, should actually be advised to wear all year round a 50 SPF on their face. That can actually make a huge difference. You know, I think things like spicy foods are really difficult, particularly with, you know, some cultures. It was interesting on the Skin of Colour Day, there's a lovely lady presenting on hyperpigmentation, and she said, you know, if I had rosacea and I was told not to eat spicy food, I'd be devastated because that is my diet. And so I think it's restricting things rather than saying no. But certainly alcohol, I love this cartoon. It's, you know, it's really important that alcohol can drive it. And people often say, well, I just have one glass of wine a day, but just check on the glass size, you see, because this glass of wine a day could be much more damaging than that glass of wine. And also red wine seems to be worse. So I always say, check the glass size. I love that cartoon. Stress, we know lots of people get stressed. And when we do the case study, we're going to explore some of these issues and triggers, but certainly, you know, people with rosacea then might try and use all different products on their face, and they can irritate it and getting overheated as well. So there's quite a lot of good health education advice. In terms of treatment, there's been quite a change in treatment with rosacea, because I think up to now that the treatment was really, if you've got rosacea, the topical treatment is metronidazole gel, and I'm sure you'd all agree with it, and I'm sure that's probably, maybe that's practice now. But I just want to say that, you know, we really need to try and move on from that a little bit. And so when it's just literally red flushing, it is a vascular issue. So brimonamide, which is a topical gel, it actually acts on the alpha receptors of the small blood vessels, and it's very, very effective. So if you think of it with metronidazole gel, it's a topical antibiotic. So if you've got no infection and it's a vascular facial condition, you're not going to treat it with a topical antibiotic. But of course, if you have papules and pustules, and you know there is a little bit of bacterial activity, it's more relevant for the papulopustular. So if it's just red, you know, just cut any topical antibiotics. There's no indication. And sometimes if it is quite severe, you may even need to add in a systemic beta blocker as well. And of course, privately, laser is quite a good option actually, but of course it's not available on the NHS. And of course, the other thing you can recommend is medical camouflage, where you have a skin match camouflage. So when you've got papulopustular, and as I say, you've got the same symptoms as acne, you have a different treatment pathway actually, and the PCDS treatment pathway lines this out very well. And really, one of the best treatments at the moment is a cream called Solartra or ivermectin. Now, why ivermectin is so good for papulopustular rosacea is A, because it has anti-inflammatory effects, and B, it actually reduces the presence of a little mite called the Demodex mite. And one of the causes of rosacea, which is a recent discovery, is that it's an imbalance of the microbiome of the skin. So basically, there are three causes for rosacea. The first cause is dermal damage. So certainly in my skin cancer screening clinic, I see a lot of people who've used sunbeds heavily in their younger days and are regretting it and coming for skin checks. I see a lot of rosacea in people who've used sunbeds heavily. So that supports the dermal damage theory, which is initiated by damage and often the sun. The vascular theory asks patients if they also suffer from migraine, because actually there's a real link between rosacea and migraine, which supports a vascular therapy. And the Demodex mite is just more prevalent in certain groups. And also the Demodex mite doesn't like younger skin. It often increases in population during the 30s, 40s. So Solartra often reduces the Demodex mite, and we really find it marvelous. I mean, Rosex metronidazole gel is there as a second line, and then acylic acid is another, a treatment which again we've used for acne sometimes. Systemic treatment, again, we tend to use doxy first for papulopustular, then limacycline, and we have Oxytec and erythromycin as alternatives because there isn't as much resistance with rosacea as acne. We look at the initial treatment for 3 months as a low dose. And then we then maybe consider a long-term option, but again, we generally review after 3 months. But I think if you do antibiotics for 3 months and then you move people, you use it in conjunction with ivermectin, because again, you wouldn't use it in conjunction with metronidazole because you don't want to mix the two, topical antibiotics and oral antibiotics, then it's really useful because you can then continue with Solartra, and we've had really good success, and I think we are reducing antibiotic use in rosacea very well. There is low-dose isotretinoin. It's rarely used in rosacea, but it is there as an option. And I think there's, the dermatology referral would be there because it might be more complicated. As I've mentioned about rhinofiber and ocular, I'm just sort of pushing on a little bit. But remember, if people have ocular rosacea, you would definitely not use isotretinoin because retinoids can worsen symptoms and they can actually lead to keratitis when there's ocular rosacea presence. So as I say, that's your ophthalmology referral. Great. I think I'm catching up a bit. I don't know if there's a couple of questions on rosacea, but I probably will, or whether I should push on.
No, I think that the chat's reasonably quiet. I think we're all right on that. So
remember, after coffee, we are looking at case studies. We've got plenty of time. So eczema, there we go, your range of eczema. Again, I'm going to do this fairly briefly because we've got a lovely case study on a child with eczema, and I have the child at 6 months and 6 years old because we know there's a bit of a difference. But as I say, there's your cradle cap, so not eczema as such, but eczema often in babies then will be often very focused on the face and the scalp. So as soon as that child's scratching their scalp, even if the mum says, oh, the cradle cap's really irritating, look at the face, look at other areas of the body, it's going to be eczema. I can say that with my hand on my heart. Obviously in children, you get the flexural pattern, but please remember it's very different in different skin types. 85% of my patients in Birmingham are probably skin type 4 to 6, and the most lovely families. And they're often so relieved to speak to me because they said, often the eczema hasn't been treated seriously because redness isn't seen. Of course, this poor little mite has really red sore skin. This eczema is far more severe than this eczema. It's actually more severe than that eczema, but it's perhaps not addressed because of the pattern. Remember, in dark skin, you also get reverse flexural patterns. You often get a plaque form on the knee and on the elbow, whereas the textbooks, and we're really trying to address this in dermatology and have many more images of darker skin because it's just not fair. There's not enough representation. And, I do think these children are often referred much later for help because it's not recognized, and it's nobody's fault, but we've got to really, really recognize skin conditions, different skin types. In fact, I'd love to do a presentation on that in how dermatology presents differently in different skin types. You can get some really awkward eczema in children. This is a horrible pattern of severe discoid eczema. Eyelids are quite difficult. We are going to address that in the case study, by the way, so that's good. And with adults, you've got the different types of eczema. So atopic eczema can be really severe as people get older. Sometimes they've had a history of eczema, sometimes they haven't. They can get the physiological asteatotic eczema. Discoid eczema is a big problem in middle-aged adults. We're seeing this a lot, even in absence of an atopic history. So of course, you know, eczema, we often say it's endogenous, comes from within, or it's endogenous, which comes from an outside influence, such as an irritant, so an irritant dermatitis or a contact dermatitis. So this would be a contact dermatitis, so that might be something related to occupation. We've probably all had irritant dermatitis in the last year with hand washing and hand gel use. And then you get other types which relate to other conditions. So varicose eczema is always there in presence of varicose veins or insufficiency of the vessels. And then seborrheic eczema, which is very different in adults, again, is more of a sensitivity to a yeast called Melisma furfur. So this type of eczema, you also need to add in anti-yeasts. So as I say, there's a big range of eczema, and it's really important to distinguish between different types. Again, this is similar to the rosacea one, but different. In fact, interestingly enough, we've got 4 of the same pictures, and heat as well, maybe, but there are other triggers. I haven't got time to go into all the eczema triggers this morning, but suffice to say, patients often say, and they'll say to you, I really want to get allergy tests. So I would say, first of all, please discourage the high street allergy tests. They cost a lot of money, often up to £500. I often sort of say to people, you're not necessarily going to gain anything. And also there's no regulation in these tests. But however, if a child does seem to be allergic, particularly under 2 to food, and milk allergy is still the most common, although that can stand aside from eczema, but there are other foods, wheat, dairy, and then the more worrying allergies such as latex, shellfish, which will last for life, whereas a lot of children will actually, it's all to do with an immature gut, so they'll grow out of their food allergy. Often children with severe food allergies, they don't just have skin symptoms, they have gut symptoms. They're the colicky baby, they have smelly nappies, lots of diarrhea. And often if they have an IgE reaction, they have a food substance and they immediately become red and urticarial. There's an awful lot more to say about food, and it's a subject in itself. But I think also parents want to go down the food track often. I often have people saying to me, and, perhaps a mother might say to me, I really don't want to go down the steroid road, but I kind of want to take all milk out of child's diet. So I say, well, why are you saying that? Because if you take all calcium out of a child's diet, you could actually cause more harm without a proper monitored diet if there was a food allergy. Whereas if you used a mild, moderate steroid, it may just treat your child's eczema. And they still say, but we don't want the steroid road. I say, I'm really interested where this road leads to, because sometimes it can actually lead to the eczema being controlled. So it's quite interesting. I love steroids because there's so much debate. I'm going to do my PhD on steroid phobia and concerns, I think, when I get around to it. But anyway, if you did say children with eczema, if all children with eczema in the world were tested, it's really interesting because a lot of them would be irritant to certain things, but not allergic. So certainly irritant to soap. If everybody was tested, everybody would be allergic to house dust mite and everybody would be allergic to pollen. And I say, well, that's quite tricky because you can't get rid of house dust mite, and in the spring you can't get rid of pollen. And a percentage will be allergic to their pets, but you do need testing for that. People really fret about washing powders, and the washing powder went back to before we had the automatic washing machine with the rinse cycle that took out all the powder. I always say, this shows my age, it goes back to twin tub days where you had Lux Flakes and you can get rid of everything. So don't fret about washing powder. Just make sure the clothes are well rinsed and don't use fabric conditioner, because it's actually the fabric conditioner that causes the problem, because generally with modern washing machines, the soap's all washed out. So there's a whole fact sheet on the eczema site about household irritants, but it's amazing how myths just stay. And it's really interesting. So I say, rather than get those expensive allergy tests, what you need to do basically is adapt your house a little bit. Focus on the bedroom. If the child's sleeping on an old mattress, which they often are because it's been passed down, buy a new mattress and buy some anti-allergy covers. And it's a much better way to spend your money rather than get allergy tests. So that's just my very practical solution, really. And I think that can make a difference. But obviously, eczema is a problem because it's an itchy skin condition, and it's all to do with dry skin, because there is a derangement in the skin barrier, which I'll come on to. Dry skin becomes itchy skin, becomes skin that's scratched and damaged. Then it leads to more eczema. Often infection comes in, and you get this whole cycle. So I think the key point from this slide is, and I get slightly upset because a lot of the patients I see in my NHS practice, the GPs trying to do their best, but they generally prescribe two things which I'm not happy about: antibiotics for red skin when it's not infected, and antihistamines. Bags of antihistamines, non-sedating and sedating. So the key thing is that for itch, the treatment in eczema is emollients, because you're repairing the skin barrier. That's what's causing the itch. Histamine has a very, very limited role unless it's urticaria. There's no role for non-sedating antihistamines at all. And we sometimes prescribe sedating antihistamines short-term, generally for children, generally some Piriton, only at night to restore sleep. I once had a patient who had been prescribed, because he was so itchy, hadn't been prescribed emollients, but he'd been prescribed 5 types of antihistamines. And he basically said that, and topical steroids, and he basically said he had very severe headaches. And guess what he put it down to? The topical steroids. So I rest my case. So that was interesting. So skin barrier, the normal skin barrier without eczema is rather akin to a brick wall. So allergens and irritants are not getting into the skin because you've got a nice barrier. You've got physiological lipids surrounding nice even corneocytes, which are filled with water because we've got good high levels of natural moisturizing factor. In dry skin, and the reason why some children grow out of eczema and some children don't is because we do know that 50% of people with eczema have a filaggrin gene deficit, which means they have a compromised skin, which is rather like a dry skin wall, actually for life. So that's why emollients are not for Christmas, they're for life, they're for every day. And this is why some children, then their eczema gets better, because perhaps they don't have this deficit and they don't have this barrier problem, but we don't know who does or not because there's not a test. So basically, without the filaggrin gene, which restores a skin barrier in eczema, and the dry skin and the itchy skin and the damage, environmental factors get in, water's lost, the skin sites are continually shriveled, and there's a broken barrier. So this is really when your emollients are absolutely key. Oops. Oh, yes, I'm going to talk about emollients, but the first thing is a little interactive interlude. So you can choose more than one word. So I want to know, which words would you use to describe, when you're teaching somebody to describe emollients, which words would you actually use for emollient technique? I'll give you a clue. There are two that are wrong and 4 that are right. And there might be an order to it, which I'll go through. Yeah. Can you vote more than once? Perhaps you can't. Might be the...
That's what I was going to say, Julie. I tried to vote more than once and I couldn't.
Oh, that's such a shame. I'll have to look at the minutes.
So I think, well, people are going for the...
Yeah, that's right. That's good. That's good. Well, I love livery because that is number 1 point. So that's very good. We like dot and we like stroke and we like smooth. What we don't like is rub or thinly. There are 2 words beginning with R that we don't like in dermatology, and that's rub and rash. So we tend not to use them. So yeah, sorry about that. Next time I'll use the slidey scale, because then you can have more than one choice. I was trying to mix it about. So the idea is that you use emollients liberally. So children 250 grams and adults 500 a week, which a lot of people don't choose. In fact, most of my patients don't. And that you can make a really big difference. You incorporate it into your routine, but the idea is that when you apply emollients, you dot, so you dot the emollient on the limb, using it liberally, and then you stroke and you smooth it down. Rubbing actually stimulates the scratch. So I'm sorry about that. I hope you have more than one choice. So dot, smooth, stroke, and you mind the gap because you try and have a gap between your applying topical steroids and emollients. But we hope that emollients are your everyday and your topical steroids are just your burst to treat your flare. Product, it doesn't really matter. I don't have a favorite emollient. I really don't. I try and match it to what the patient likes and suits them. But the most important thing is you need to look beyond the brand into the actual formulation. So not emollients are the same. And basically you've got within leave-on emollients, which can be used for washing as well, which is really, really important because we talk about complete emollient therapy. We don't tend to prescribe bath oils anymore, but I think they do sometimes have their place, and we might leave that for the case study discussion. So you've got a simple occlusive, a heavy occlusive, and a humectant occlusive. So within that, you can fit the brands that might suit. So a simple occlusive means that you literally just repair the barrier with a film of emollient, which occludes the barrier. Now, a simple occlusive, a lotion will hardly last. Quite good maybe in a hot summer, but not so good really for eczema. It's not enough occlusion. It probably only lasts with eczema 30 minutes to an hour, whereas the creams and gels could last up to 2 hours, maybe 3 hours. The problem is you need to keep applying it. So perfect for a baby, every nappy change. Great, use a simple cream. A heavy occlusive is much heavier, it's much greasier, but it's really good at addressing dry skin over a long time, but it's really, really messy. So the little boy we saw with his little legs, very dry skin, again with darker skin types tends to be drier. Fantastic, use a simple in the day every few hours, and then at night a nice thick layer of emollient to really soak in and address that dryness. And that works really well. So sometimes you need one of two. A humectant emollient is really worth considering because you've got a dual effect. As well as the occlusion, you've got natural moisturizing factors coming into the skin, and basically they're restoring the imbalance because we know that eczema has 30% less natural moisturizing factors. Absolutely brilliant because they're cosmetically acceptable. People can put them on in the morning, go to work, go to school. They may need to apply in the middle of the day, but actually a humectant emollient can last the whole school day for children, whereas a simple only lasts 2 hours. So if there's problems with applying at school, do think about one of the humectant emollients. They have active ingredients, so they have things like glycerin, urea, isopropanol. So you've got your double-base day leave, you've got your Balneum, you've got your Olatum, you've got your Avena, you've got your Aproderm colloidal. If you want to know the brands matched to the formulas, just download the emollient fact sheet from the Eczema Society. Again, you know, with more time or just eczema, I have more time to go through it. Topical steroids, again, we're going to talk about this in the case study, and I'm aware that, you know, I really want to finish this morning session in time. You've got to match the steroid to the age of the child, the severity of the eczema, and where you are on the body. You've got to use enough. There's a lot of topical steroid phobia, and it's really, really important that you use steroids therapeutically in fingertip units. So you have one arm, and you measure with an adult farm 2 areas of topical steroid. You need 1 fingertip unit for that area. The other really important point is you only need to use topical steroids once a day. There is no justification for using them twice a day, because actually there's a really good paper that compares once a day with twice a day use. So you can immediately reassure parents in particular of reducing topical steroid use because you only need them once a day. So I favor a really good nighttime routine. You have an emollient bath, you pat dry, you apply the steroid, you wait 30 minutes, you give the child a cuddle, you read a story, and then you apply the emollients. And then in the morning when they're going to school or you're going to work, you only have to apply emollients. I know there'll be lots of questions and I am galloping on a bit, but just remind people there are 4 groups. You know, it's really important not to necessarily creep up the steps, but if you've got a child or 3 or 4 with quite severe eczema, use your potent. And what we do is we use a technique where, oh, sorry, I'm just going to move on from this because I don't think we've got time to do it, sadly. We get control. So you use the topical steroid every day for 2 weeks, every night for 1 week, and then every other night. And then if the eczema is not quite controlled, you may continue with 2 consecutive days during the week, often for a few weeks. So often you can really get that control if you focus on that 2-week burst. So what we've missed is some quick guidelines on topical steroids, and I was going to ask you if you knew any. We can possibly come back to this in the case study, but as I say, I think the questions might be more important. I just was going to show you the PCDS guidelines, the treatment pathway, but again, we will discuss that in the case study. But they have a nice ABC, so avoid triggers, use bland emollients, and control your inflammation. If there's no response, you need to think infections, and this is a really, really important study. You don't prescribe antibiotics for red skin, only if you've got signs of crusting, weeping, and oozing, and eczema that's not responding to steroids. So this is infected varicose eczema, not cellulitis. So remember, cellulitis is unilateral, and the red flag is eczema hepaticum, which is a viral imposition of the herpes simplex virus, which can really cause a very, very nasty viral reaction. Often people need oral, quite often children, IVA cyclovir. I'm really glad someone mentioned immunomodulators. They are so underused, and particularly for faces and sensitive areas and even long-term maintenance. I think they really should be considered. They are just licensed over 2. There is sort of experience of using Elidel under 2. So we're talking about Protopic and Elidel, tacrolimus and pincrolimus. So if I have somebody with facial eczema, we generally can try and control it with some Humivate, generally say for face, 5 days, then 3 days. We have to be really careful of the eyelids because they're thinner, and that's where you could run into problems of long-term steroid use, but immediately try and move them to a TCI because they can be used and they can be prescribed in primary care. The BNF still says a specialist, but actually NICE says anybody with experience of managing eczema, and that's what they term as a specialist. So they are fully prescribable in primary care. Slight problem is a 30-gram tube of Protopic is 5 times more expensive than the 30-gram tube of hydrocortisone. But what I say is it lasts a long time, often lasts 6 months to a year, actually, because you don't need to use very much. And once you've got under control, you only need to use it twice a week. So I do think they're very underused. I'm just going to push on to psoriasis really quickly, Helen. Is that all right? I might actually have to skip the infection side or come back to it at the end of the morning, I think.
Yeah, that's fine. We've got a few questions, but we can.
Yeah, I think yeah. So I'm just going to go through psoriasis because I want to stop for coffee at 1:15, because otherwise we will run out of time for the case studies.
Right.
Although the case studies might not be an hour, it depends what people want, but I don't want to cut in. So psoriasis is quite complicated. I think the key thing is, a bit like eczema, which has emerging comorbidities, these are not just skin diseases, they're complex immunological conditions. And as I say, it's a chronic disorder. Generally, chronic plaque psoriasis will develop late teens, early 20s. You see it on the knees, the elbows, and the scalp is very much part of it. So often ask about the scalp. And with the scalp, we have a little bit of protrusion onto the face, the hairline. What strikes me about this psoriasis is it's completely untreated. A lot of people with psoriasis don't necessarily seek treatment and don't want it unless it's acute. So guttate psoriasis is like small plaque psoriasis, a raindrop psoriasis. This is triggered by a streptococcal throat. So the teenagers who are having tonsillitis, think of that. One of 2 things can happen. In the absence of a family history, perhaps it just settles and goes away, but that person always have the potential to develop chronic plaque psoriasis. So, it often can be a forerunner to chronic plaque psoriasis in the teenage years, and then psoriasis may develop later. There's a very, very strong link between psoriasis and arthritis. It's well established, and 30% of people with psoriasis may develop psoriasis. Generally, small joints, you see the dactylitis here, but again, look at the nails. In fact, there's onycholosis there. There's probably some fungus there as well. So often the nails are a really good clue to psoriasis as well as a diagnostic sign, because nails are often affected. The guidance say that anybody with psoriasis should have a pest screening tool to identify early arthritis, because when you think there's 30%, it's really important arthritis is addressed sooner rather than later. So do this PES score. It's very simple. It's 5 questions, and if there's a score or 3 or more. I looked after a boy, well, a young man, I should say, rather, with psoriasis, and I was really worried about his psoriasis. And you know, he said it affected his sport, and I immediately thought, oh golly, I'm sure he has arthritis. I did the PES. He had a completely 0 score, and of course, you know, sometimes, you know, psoriasis isn't indicated, arthritis isn't indicated. It's also really important with people with severe, even moderate psoriasis, that you do look at the cardiovascular links. When you're seeing patients, if you're seeing patients with high blood pressure or for cardiac reasons, for vascular assessment reasons, you might be surprised how many have psoriasis or have metabolic symptoms. Syndrome. It is connected, psoriasis, with diabetes, metabolic syndrome, and hypertension. And people with psoriasis are much more likely to have an MI at an earlier age than the general population. There's lots to say about the comorbidities, but I just think keep it in the back of your mind. And of course, this lifestyle advice is the general lifestyle advice for cardiovascular risk. Sorry, I'm galloping slightly because I want to stop for coffee in literally 3 minutes. Management, again, we look at emollients first line, and then we look at generally combined calcipotriol betamethasone. Really important because actually quite often people want to use things singularly or just go for a plain steroid or plain vitamin D. You're better to try and combine them. You do get a much better outcome, and this is in the guidelines. If you've got large thin plaques, you can look at a tar solution, so XRX or Alpha-Sil, but on the face, you need to very much stay with a plain vitamin D, and if it's slightly inflamed, you can use a moderate steroid. The young man in question had actually quite bad facial psoriasis. Thankfully, it's quite rare, but as I say, I would generally look for a plain vitamin D and no steroid on the face. The old-fashioned treatment options are still there. I haven't used Diffra Cream for years, actually, although I think it's quite useful sometimes for people who've liked it in the past. So you always need to ask patients what treatments they've liked in the past. I think when you have thick scale, even on the body, and I'm coming to the scalp in a minute, you sometimes need to simply descale because most treatments won't work with a thick layer of scale. And that's the problem with psoriasis. You've got this proliferation of corneocytes, which leads to this thick scale. So sometimes you need to even use some salicylic acid on the body. If I've got people with very scaly psoriasis, I'm in the habit now of prescribing diprosalic in the morning for descaling, and then Dovabet at night, because Dovabet's once a day for 4 weeks, but it does also have a license for maintenance. The expectations are so important with psoriasis, and so many people fail because they don't understand the expectations. So the quick run through is very scaly plaque, untreated. Again, I would say diprosalic AM and Dovabet PM. The Dovabet actually will immediately, or the calcipotriol betamethasone, and as I say, you know, there are various forms of it. There's gels or foams. The foam's really nice for the body, actually, and the gel's perhaps better for the scalp, but you can use foam for the body and scalp and gel for the body and scalp. It's formulation. After 2 weeks, particularly with including emollients, perhaps diprosalic, and then Dovabet the side of the day, what happens is you'll just get rid of the scale, and the Dovabet really acts on the scale. So what you get is you get a plaque that was actually quite protected from this scale to actually getting quite a red, tender area. At this point, a lot of patients say to me, well, we stopped because it's gone red. It's an allergy. It's not working. It's sore. So just say to them, no, that's exactly what's going to happen. It's a bit like acne, it's expectations. And you say, carry on with the red area, feel for the rough redness. Often psoriasis can actually clear from the center out. And then you get to 4 weeks and you see there's only a tiny patch of psoriasis here and a little bit here. And this is what I call the shadow of psoriasis. And again, sometimes these pigmentation problems can be more prominent to people with darker skin. So the shadow of psoriasis means that you're just using emollient here and you're only using your Dovabet on these tips to actually get through and treat the psoriasis. And these images actually were taken from patients who were very, very regimented in applying every day for 4 weeks, because they actually these images, they were given to me by Leo, they actually came from the Dover-Bet trials. So this again proves that if there's good adherence, you can get good results. And I think this is something pharmacists are brilliant at doing. You're really, really good at helping patients with adherence, better than most actually. So with scalp, you are looking at the shampoos, the tar shampoos for milder psoriasis. But remember, if you've got thick scaly plaques on your head or thick scale, nothing is going to penetrate again. So I'm very, very fond of a really messy preparation. I apologize to my patients, but you can remember it. Think of the Olympics, I say Sebco or Cocoas, but Sebco is slightly cheaper. So you prescribe 3 tubes for 3 nights. Literally, if they've got thick scale, it's a tube a night. It is ultra liberal. Massage it in, cling film at night, old pillowcase, the next day, wash out with tar. Now, the directions say leave in for an hour. Doesn't work for an hour. This is 30 years experience. It's got salicylic acid, tar and coconut oil. There's no indication for it not be left. So, you know, consider descaling and then things will really work, because then you'll just be left with red plaque. You can also, if you want to use a plain topical steroid on the scalp, which is fine. Often if you've got Dover-Bet for the body, you may as well use it for the scalp. Just go for a lotion, because scalp applications shouldn't be called scalp applications. They should be called stinging applications, because alcohol always burns, inflames skin. So I go for a lotion or a beta mousse, which is beta cap. Etrifex shampoo has a place, but remember it's very potent and a lot of people think it's a shampoo. Use it in the shower, get it on their body. You don't want very potent steroid on any skin, and not psoriatic skin. You could cause a rebound. So they use that, they soak it on their head for 20 minutes and then wash it off over the shower. I'm not very fond of it because I just think people use it in the shower and get it on their skin. And I think the old-fashioned descaling works a treat. So there's lots of quip guidance, and I had one for topical steroids, and it's really, really useful, this quip guidance. Sorry, excuse the Q, just ignore that. There's always a Q after, there's always a U after a Q, but it's actually QIPP. So do look at your guidance. There's really good guidance for emollients, topical steroids. And remember the patient support groups. You know, there's 2 for eczema. I work with Allergy UK as well, and they're fantastic for the allergy side. You've got the Psoriasis Association, you've got PAPA, which also incorporates arthritis, and the BAD have a great acne support site as well. So I don't think I've got time for skin infections, have I? Should I just whiz on to COVID?
I would think not. Well, should we go through just as a couple of questions, mainly on the eczema? Sonia wanted to know in terms of steroids, once daily, is that for all steroids? All of them? Would you just?
Yeah, all steroids should be used once a day. It's a lesser known fact, really. The problem is the labeling. I'm ever so sorry, but they're often labeled 2 or 3 times a day. And they're often still labeled use sparingly. And did you know use sparingly was taken out the BNF 12 years ago and replaced with use thinly? So hopefully you've got thinly rather than sparingly. Okay. But it's really difficult because the BNF, also in the BNF, often it says twice a day, 3 times a day. But I can share the paper from Hal Williams from the Nottingham Centre of Dermatology. But I just think it makes such a difference, because if you're using it once a day, you can use it properly with the bath time routine. I mean, who has time in the morning to apply steroid to their child, wait 30 minutes, then apply emollient, get them dressed out the house for school? It's just not practical. So I think the once a day is really, really useful, because once parents, I'm really, really pedantic about a bedtime routine, particularly with children. For all sorts of reasons, and a daily bath as well. But we're going to look at this in the case study as well.
I think that's really, really important message. And I think, you know, some of these things have changed a lot. You know, I think the messages from, 10 years ago for some of these things are dramatically changed. Uma says, what about the use of dermal lotion for washing?
Yeah, great.
Should you prescribe and step down using emollient as soap substitutes? That's 2 questions there.
Yeah, I mean, I think all emollients can be used as soap substitutes apart from 50-50. So that's the principle. So if you can get one emollient that does everything, that's fine. If you've got a child who's having frequent flares, it's quite useful to add in dermal, because you've got some antimicrobial, and remember, you've got 80% more staphylococcus on eczematous skin as you have on normal skin. So I'm a big fan of dermal lotion for washing. Actually, I think it's a nice addition because, as I say, you're just reducing the bacteria with a very gentle antimicrobial, which isn't an antibiotic, and it's a nice solution to wash with. They also do a shower gel, but that's not got antimicrobial in. But as I say, the principle is this complete emollient therapy. So that's good.
Okay, fantastic. Erica wanted you to touch on the management of Pomfrix eczema.
Yes, again, I mean, Pomfrix eczema is basically a division of hand eczema. It's when hand eczema is probably most severe, and Pomfrix actually comes from Greek from bubbles, so you get little vesicles which are really incredibly itchy. So I'd say it's the severe end of hand eczema. It sometimes can be the severe end of a contact dermatitis. So you actually perhaps need referral because because contact dermatitis is most common on the hands and the face. So any eczema resistant hands and face, you need to consider a patch test referral without a shadow of a doubt. So that's useful to know, although you can't get a patch test referral at the moment, unfortunately. But anyway, we're hopefully better in as the year progresses. But actually, I think the key message is, if you've got someone with Pomfrix, it's acute, severe hand eczema, and actually you need to go right to the top of that steroid ladder. Don't mess about. You do probably need, a 2-week course of Dermavate to settle it down, and lots of emollients. And people often get very frightened of using Dermavate. In a small area such as the hands, particularly making sure people, when they apply it, they wait their 30 minutes, they apply their emollient and only apply it at night, and then maybe even pop on a pair of thin cotton gloves, because what you don't want to do if you have Dermavate in your hands is touch your face. So again, this also is another really good argument for this just nightly use. But you may be fine with a Betnovate or Elicon, but as I say, I think with hands the skin's much thicker. You're not going to have, for 2 weeks, you're not going to get any side effects from steroids. The side effects from steroids come if you're using topical steroids week in, week out, literally for 2 or 3 months, and you're not having a break. But the 2-week burst, the stop, and then a long period of emollients, you can use. We do know. We all know how to use steroids safely. The problem is there is still so much ultra concern, and as I say, I only advocate short bursts. But with hand eczema, it is an area of the body we need to go a bit higher, really, but also consider contact allergy. Do you want to stop the coffee now, and then I could just?
We got a couple more. If you could just answer this. Suctic. Okay. Do you recommend the use of Estella foam in treatment?
Oh yes, yeah. Estella foam is, sorry, I was trying to speak generically betamethasone and calcipotriol, but because I was speaking so fast, I was tripping up. So that's, I said Dovabet, but Estella foam, basically Dovabet has a family, okay? So you've got a family of Dovabet. So you've got a cream, you've got an ointment, you've got a gel, and you've got a foam.
Okay.
I quite like the foam, but they're all the same. So it's matching the formulation. But often, I think patients with psoriasis, particularly if they're in their, 50 plus, they often have real nightmares of, sometimes being admitted, being covered in tar, or being given smelly tar to use at home. And then Estella foam is really nice because it's just such an easy preparation to use. The gel is a bit tacky and sticky, but then maybe if you've got drier skin, the gel's a bit better than the foam. But it's all about this sort of matching the formulation to your patient rather than the brand. That's kind of how I work. Bit like emollients, so that's why I don't have a favorite emollient. I sort of match the formulation, but it's just sort of getting your head around that. But you're good at that, pharmacists are great at formulation, that's your thing.
Okay, Helen asks, what do you recommend with people who want to have steroids longer than 4 weeks? Try not to put it on repeat, but often the patients want to have it on repeat. There's quite a lot of the other way around, people asking for more steroids.
You see, I think that is a real problem. And I often think, have they really used it properly for that short-term burst? So I would go back to basics with them, because what happens is you find patients get a flare of eczema. They use their steroid for 2 or 3 days. And what happens is it's a bit like a fire. They get rid of the flames, but they're left with the embers. And then another few days later, those red hot embers, they haven't quite died down, so they burst up again. So then they use them for another few days. And then you get this cycle where they feel they can't do without them. So what I say is if you use it for the 2 weeks, so once the skin has got a lot better after 2 or 3 days, which it generally will, carry on. 5 days on the face, 7 days on the body, till you get to a point where you've actually got through the ember stage. And I think the fire analogy is quite good. And then you've got because what happens is I think a lot of people with eczema get stuck in what I call the subacute. So you manage the acute because that's infection, that's severe flare, but then you've got this rumbling subacute. And I think that's the group of patients who want their steroids on repeat all the time. So I think if you can bring in this sort of 2-week cycle, this sort of get control, keep control. But for some patients, you might need to bring in the weekend regimen. And again, that's all explained in PCDS. But if you I think the problem is, as I say, and then the patients say to you, well, I think the steroid's rebounding my eczema. And I always say, actually, the eczema's rebounding because it hasn't been properly treated. It's much more an eczema rebound rather than a steroid rebound, because you don't truly get a steroid rebound unless you're using a very strong steroid such as Dermavate for 2 or 3 weeks. And there's other things going on, really. I mean, it can happen, but I think it's just, I think subacute eczema management is really a real skill. And if you can manage that with your patients and you can get them to use longer and longer emollients, you really will be on more of a win to control. And again, I think some patients just have really severe eczema, and the topical treatments, like any condition, just don't work anymore, same as psoriasis. So that's when you need referral, because they may need light therapy, immunosuppressants, and indeed we have the new biologics coming through, and new JAK inhibitors for eczema, which is really exciting. So I think, some patients actually, their skin isn't controlled with topicals, and then you have to, like anything, work up a ladder. So, but it's an interesting challenge.
It is, Julie. I'm going to ask a few more questions. I know we're running late, but I really think it's important that we meet people's questions, because that's really key. And if we have to squeeze the other half, and we're not limited to any sponsorship here.
No. So we have got till 12:30 or more.
Yeah, and if we end up with like 5 or 10 minutes break, well, people can leave early,
Yeah, and the case studies, we will reiterate quite these points. And as I said, I've still got my COVID skin signs up, because we might not get onto infection today, but don't worry, we can have that for another day. But I would like to run through my skin symptoms of COVID.
We've had a complete ambitious program this morning. Sonia asks, for scalp psoriasis, which treatment do we use, and when do we wash with the shampoo?
Yeah, well, I think thick and scaly, good old-fashioned descaling. I'm afraid you can't get away from that. It's really interesting. You sort of describe how messy it is, and patients like, oh, I say, well, just for 3 days, just, and then I review them. They say, gosh, that was marvelous. That was marvelous. My head felt vice-like. They said it was really messy, but it was really worth it. So descale first, as I say, then add in your psoriasis treatment. So, as I say, I think if you've got the Dovabet Estilofone prescribed for the body, just add it into the scalp when you've descaled, because it just saves another prescription. The foam probably it does work on the scalp, but I think the gel's a little bit better. And as I think I've said this, actually, I'm repeating myself. So sometimes I do use just a topical steroid, Betnavate, but lotion rather than solution. I just think I'm just completely repeating myself from what I said.
Okay, and we'll probably repeat it again sometimes in the presentation. That's fine. Hugh asks, what could you share that paper? Presumably she means talking about the
steroids. Yes, yeah,
because I think that's really important, because the BNF BD, everybody thinks BD. So if you've got evidence on that, you can share with us. That would be absolutely brilliant.
I think the problem is it's not in the BNF, and is because with the BNF takes their information from the SPF, SPCs, sorry, not SPFs, that's something else, that's sun's protection, SPCs, and basically most of the SPCs for steroids, they're like what I call rolling SPCs, because the topical steroids have been around for such ages. So often, and there are so many of them, that the companies don't necessarily put in that once a day, or don't even know about it, because a lot of steroids are cash cows for pharmaceutical companies, aren't they? I'm not being rude. That's a marketing expression. That sounds really a bit rude, but it's not. It's just that they don't necessarily, I'm not saying they don't review their SPCs, but I think they wouldn't necessarily put in the once a day, because they might have to then go back to clinical trials of that particular brand. It's all a bit confusing, really. So it's best practice once a day, but I can share the paper. Again, I can dig up the reference at coffee again, if you like.
That would be really helpful if you can. And Uma's got a case of a patient with chronic renal disease and itching. Is this something beyond our session this morning? She says
a little bit. Chronic
yeah.
renal disease and itching is very much to do with much more complex factors to do with the renal disease itself, but
and phosphates and stuff.
Phosphates and things. So it's a bit more beyond our session.
I think Uma, I'm going to say to Uma, I think that's beyond today.
Yeah,
I think that's more of a renal specialist question.
I think so. Although you can give the patient really good advice on emollients, and if they are particularly itchy, there is a very small range of emollients. They are more the expensive end, but I would say for that patient, I would certainly get them to have a good emollient regime, because it would provide some comfort, but use perhaps Balneum Plus, which has lauramacrogols in, which is a local anaesthetic. So I don't prescribe that often, but for renal patients, it might fit. Or the other thing is that patient perhaps needs, and again, it's a bit of a wishful dream at the moment, but a joint dermatology renal consultation to look at the skin.
Yeah. Okay. I think we're going to leave it at there and grab a cup of coffee or a cup of tea. What time is it now? When do you want?
Soon symptoms of COVID.
Yeah,
because I just think it's just useful. There are only a few slides because there are sort of 7 skin symptoms, but I do think it's possible. It's possible you may pick them up, and we certainly had a few patients referred on advice and guidance, and we've immediately said to the GP, test time, this could be COVID. But we haven't had any feedback, unfortunately. But it's quite useful. Now, interesting enough, I've just had some personal experience, because very good friends of mine, they all had COVID in Oxford down the road. From their naughty teenage daughter who went out to meet her friends. Anyway, so I said, oh, how were you? And very interestingly enough, because my friend who's called Flo, obviously knows I work in dermatology, she said, well, Judy, she said, 2 of the 4 of us got skin signs. She said, I didn't even know they existed. And apparently her son. And I almost said, oh, too late, but I wish you'd taken a picture for me. Could have used it in my teaching. He had COVID toes and no other symptoms. He just literally had little purple toes, and Alex is 13. And Flo had 3 days of acute urticaria that came with a vengeance and went with a vengeance. And she said, and I said, well, that's really interesting. So that's just a recent experience, but they are on the rise. They're not, I think they're defined in the lower level of symptoms, but I just think it's, and basically they have been added to the symptom list, that's for sure. There was a big study in Spain, because I think Spain had earlier experience with COVID, and the dermatologists got very interested, and there was a wonderful paper. I actually did a paper myself, which is online in Nursing in Practice, to alert, mainly nurses, because it was a nursing audience, to skin signs, because I felt so passionate that I should get this message out. So basically, if you've got acute skin eruptions at the moment, think COVID, particularly with younger people. It's more likely to occur in younger people. So you've got acute areas of erythema called the pseudo-chilblain, and they are a bit like chilblains, urticarial, maculopapular, vesicular eruptions, a little bit like chickenpox blisters, and livido. And there's some more signs emerging for children, a multi-system inflammatory syndrome, where you get very red hands and feet, very red oral mucosa and conjunctiva. Again, symptomless apart from the skin symptoms, and also some hair loss. And very sadly, with people with I suppose we do say terminal COVID, people in ITU who are not surviving, there's some really horrible digital necrosis which we're seeing in those people at end of life COVID, which is tragic, horrible pictures coming up. So this is your COVID toes, and it's really, really distinct. I mean, they're pretty grotty toenails anyway. We haven't done infections, but there's lots of fungus there. But apart from that, can you see a really clear demarcation? So what happens is people find their toes and their feet are just ice cold, and the main treatment is to just try and keep them warm. Now, Wiley Blackwell and now the BAD actually have 2 new websites on skin signs in COVID. So there's lots of evidence coming through. So this is what my friend had. She suddenly developed this acute all over urticaria, and she described it just as this, you know, an urticaria that came up in wheels. You've got some COVID fingers and toes here because it's on the same slide. And she said it literally was, she was frantically itchy for 3 days, and then she woke up and it had gone. So very strange. So you just get this acute urticaria. And then you can also even get more of a maculopapular eruption, which also is itchy, and it's you get more of a sort of, rather than a wheels, a coming and going skin disease, which is what urticaria is, you get more of a solid presentation that lasts. So this is rather like a conventional drug reaction that, you know, you will have seen. The vesicular eruptions, you can sometimes get little pinpoint blistered areas again, and it's a little bit like chickenpox, and that's interesting, isn't it? Because chickenpox is a virus, and you get little blisters as a viral disease with varicella. So I don't think it connects to chickenpox as such, but it presents in a blister. And of course, with eczema herpeticum, which is a virus, you get runs of vesicles or blisters. And then libido is seen more in older people, where you get more of a sort of purpley patch. Libido is really described as purpley patches of skin, really. And sometimes they can even become quite raised and quite sort of knobbly, but that's unusual. It's more this presentation which you would see. So you can see some libido, which again, most of these are skin changes rather than actually causing symptoms. So this is what you might see in children on the hands and the limbs, this sort of little patches of inflammation. Again, not itchy, definitely not eczema, no symptoms, but just showing as a multi-inflammatory inflammation system. So there's something going on with the immune system causing this inflammation. And then you can also see some people are reporting hair loss. I don't think that's meant to be a rarer skin sign, but, you know, and sometimes hair loss can occur because of stress, and you know, it's a stressful time for everyone. So that's interesting. And then this is the really, you know, really sad sign that is, you know, these are sort of ITU pictures, sadly, where you're actually getting acrocenitis and actually digital necrosis. So that probably is the severe end of these COVID toes. So I mean, I don't think you'll see this, but it's just very distressing. You know, imagine, you know, seeing that in someone. Really nasty, isn't it? Oh, someone's just in the waiting room. Shall I admit them? Yeah.
It's all right. We're keeping an eye on that, Julie. You don't have to worry about that.
Okay. So basically, I think a lot of these COVID skin things are more signs rather than symptoms. There are some symptoms, obviously, the very itchy urticaria. There haven't been many studies. There was a case study of a child with COVID toes, and recommendation was keeping toes warm with double socks and foot warmers. Isn't that great? But obviously no topical steroids there. Emollients, of course, and maybe emollients, and this is the lacrimacromoles, or maybe even 2% menthol. That's another nice preparation. Try and prescribe it as Dermacol, by the way, because if you get it mixed up, you know, the old Acris and menthol, you remember all those potions being mixed up, and that was one of them. Conventional Acris cream contains sodium lauryl sulfate. So actually we know that Acris cream is damaging to the eczema skin barrier. So if somebody's very itchy, always go for the branded Dermacol purely because it has no SLS in. And also if you get things made up, they're very expensive, aren't they? Even if they're just fairly bland. So also we look at complete emollient therapy for all dry skin, and aside from skin symptoms, of course, you've got PPE symptoms, marasne, where you get sort of either acne or eczema. I've actually had some marasne myself from wearing a mask all day, as I do every Tuesday when I do face-to-face. And of course, unfortunately, we would love to tell everybody of eczema not to wash with soap because we know it's such an irritant, but the guidance is that you do need to use soap and water to wash hands to eradicate the virus. The virus is only eradicated by soap and detergent. So that's really, really tough. So what we say is we recommend a double wash of emollient. So this is really hard because, you know, there's been a whole surge in fact, I had an editor contact me from a popular magazine. I won't say which one, but it was quite a trashy magazine in the nicest possible way. And she said, I need to write an article because there's now an epidemic of eczema. on hands. And I said, yes, because people are washing their hands more. And I left it at that. I wasn't going to get into.
So Julie, is the soap a lot better than gels? And
well,
how in terms of efficacy, and how to compare in terms of dermatology?
Well, in dermatology, I think the feeling has always been that soap and water, but it's not just the soap and water, it's how you wash your hands. With washing hands, you're meant to, I think people have been taught, there's a system of palms, then fingers, and then over the palms. We all know that. Whereas with gel, people tend to go, done. So it's more about that, really. Yeah. But I think, but also I think gel is probably, I think they're both quite evil with eczema skin. I think you've just got to increase the emollients alongside or do a double wash. It's really tough. Right, we'll get more interactive now, I promise. Okay, here's Jack. Okay, have a read and see what you think about baby Jack. Sorry, you have seen one of these images before. And we'll ask some questions in a minute. I've said immunisation clinic. Sorry, I should have changed that. Comes to see the pharmacist. So sorry, I have used this case study before. Please read immunisation clinic for the pharmacist, and I will just make a note to change that on the next one. So I think as pharmacists, you would get people coming to talk to you about their babies. I know you work in GP practices, so perhaps people would come to you when they've been given a prescription as well, or maybe would you see this baby as a prescribing pharmacist? Obviously, I have got the chat function up now, actually, which I did find.
I can have a look. Don't worry, it's my job. There's nothing in there. I think generally these people that don't dispense prescriptions, the people on this line, they're not dispensing pharmacists.
No, so they are seeing. They're seeing. They are, because I knew you were, prescribing pharmacists and people who were seeing patients face to face all the time. So
not all the time, but quite a few of them are, to do medication reviews. And I think that certainly a lot of people are kind of by the way about skin conditions, but somebody may well pass this on to you. So, this could be.
That's right. Yeah. So basically what I'm saying is you would have experience seeing babies with eczema. And again, Shanaz, I hope I pronounced your name correctly. Shanaz says, yes, lovely. Okay, well, let's get on to a question. Oh, yes. Good. And so, just let's have a look at a question now. So basically, hopefully you've all read the case study. So there's a sort of order that you might consider treatments for baby Jack. So I'll just run through them. I hope it's not confusing, and I hope this voting works. So which option would you say is the correct order? Would you focus on diet, then antibiotics, emollients and steroids? Or would you focus on antibiotics, emollients, milk-free diet and steroids? Or would you focus on emollients, steroids, antibiotics and milk-free diet? Or would you focus on topical steroids, antibiotics, emollients and milk-free diets? So I hope that's not confusing, but what sort of order would you consider treatment? You might need a bit of time to sort of tease that out in your mind. So obviously, when you're looking at the baby, he's got very, very red face and looks quite irritated and scratched. But is it infected? So yeah, that's what you've got to think about. You've also got dry skin and you've got untreated eczema. You've got a parent worry about diet, but would you go down that route first? Ah, great. Got some good votes here. Yes, so excellent from what I'm seeing. Certainly number one, the emollients first. So basically you've got to give parents education generally on managing eczema and reassurance. So of course, emollients, we would always say, are first line. Because you've got inflamed eczema, and I think a lot of people think it does look infected, but I think you do have to stand back. The baby's skin hasn't been treated. It is his face. There's no visible yellow crusts. I would hold back on the antibiotics and I would treat with topical steroids first. But if he didn't respond to antibiotics, or if his skin became red or more weepy or crusty, then you may need to include antibiotics. So that's why I put antibiotics third. So agree with that. And the milk-free diet, I would just put to one side, because until you've treated a baby with eczema, you have no idea. And also, I think within the history, and probably the history was purposely not there, you may ask if the baby Jack had reactions. Now, remember, he's 6 months, so they've only just started weaning. And the problem is that eczema classically appears between the age of 3 to 6 months. And quite often, you know, because weaning has been the biggest change around about 6 months, parents often want to blame food. And as I say, I really am very balanced about food, and I always sort of put it down to the individual and whether they've had any symptoms. So yeah, I think you're right. I mean, I put emollients first because the principle is with eczema that emollients are first line treatment for all types of eczema. But I agree with number 2 that you might want to just home in on the acute first. I don't think number 2 is incorrect. I certainly wouldn't go down the dietary route first, and I probably wouldn't go down the antibiotic route first. So yeah, I hope that was useful, you know, just to tease out. So now the parents have been told that they shouldn't really give Jack many baths. They shouldn't bathe Jack. So obviously we might need to add to this, but if parents asked you, would you give them specific advice on bathing? So we've got immediate vote coming in now, which is useful. Yeah. We just wait for a bit. As I say, don't be guided necessarily by other people's answers. Do what you know, think in your mind. If somebody asked you, how often should I bathe my baby? Or would you say to them, you know, well, if they've got eczema, you should only bath them XXX. Just think what you would say.
Just to remind people, this is anonymous. There's no votes.
Yes, it's anonymous. Yeah,
press the wrong button, as I have done in the past.
Yeah, this is totally.
Nobody knows it's me.
Yeah, no, I don't know who you are, I'm afraid. I'd love to be in a classroom with you and know you all. It would be much more fun. But this is as good as we can get at the moment. So I don't know who you are, so don't worry. Yeah, okay. Yeah, I think we've had 17 votes. I think some people aren't voting because perhaps they're worried and we might know who they are, but honestly, we don't. We promise. This is just for your education. Okay. I think this is really interesting. I love this. So let me see. So why would you tell someone with eczema not to have a daily bath? I sort of reverse the question. Because people know that when children have a bath, it might dry out their skin because of hard water, because of bubble bath, because of soap, because of detergent. But what's the best way, and what's the first line treatment of eczema, which is emollients, which is complete emollient therapy, which includes bathing? So a lot of the advice is based on people using bubble bath soaps and detergents, which is wrong because you wouldn't do that in eczema anyway. So absolutely, it's a daily bath with emollients, even for a baby. And I know a lot of baby skincare is, oh, you should only bathe them once a week, twice a week. That is reversed when you have eczema, because what you need to do is you've got to get the emollients on the skin to restore the skin barrier. And also, you know, with eczema, you've also got a build-up of microbiome in terms of extra Staph aureus. So you've got to cleanse, and you're not going to affect the skin barrier as long as you use emollient. So the idea is, again, you can just use your emollient cream or ointment, cover the baby in cream or ointment, pop them in a bath, literally a 5-minute tepid bath, let them splash about, stroke the emollient onto their skin. They come out the bath, you pat them dry. Their skin's been well moisturized, and you'd always apply topical steroids to well moisturized skin, because if you apply emollients to scaly skin, most of the emollient gets absorbed in the dead skin scale. Then you would apply the steroids. So actually, again, there is good evidence, and I probably can find you a paper on daily bathing. I mean, the thing is, bath oils now are not recommended because they're considered to not be needed. But there also is a certain child, and I'm not breaking confidentiality, but this child is Pavlov's child. Have you heard of Pavlov? He was a psychologist, and he did an experiment with dogs to work out what their sort of, I can't remember what it's called now. My brain's gone dead. Their response. So that if they went to an electric fence, even if they weren't given an electric shock, they'd stand back for it. Yes, Pavlov theory. Thank you. So Pavlov theory, which you know, because we've all studied psychology, I'm sure, is the child who the parents say, I can't get emollient near them. Every emollient stings. Every time I go near the child, they scream and they run away. And the problem is that dry skin is always itchy and sometimes stingy. So if a child's had an experience of an emollient stinging, they get this, what's it called? The theory, not the theory, the response.
Conditioning?
Conditioning, yes, sorry. Yeah, conditioning, thank you. Yeah, so the child is then conditioned that every emollient is going to sting. So you've then got dry skin and you've got a buildup of eczema. So this is where I think there's an argument for the bath oil, because if you put the oil in the bath, at least you get some emollient on the body without the child, and then you can gradually reintroduce it. So as you say, think of Pavlov's child. That's just a Julie thing, really. But I think that's sort of just because I've looked after children with eczema for actually 30 years now. So you build up this experience. So yeah, the daily is definitely the correct response. And actually, I love dermatology because you can make very small changes which make very big differences. And certainly incorporate getting daily emollient bathing back is a really good thing. Great. So anyway, all children grow up, and now Jack's 6. So actually he wasn't milk allergic. He didn't have a food allergy. The parents worked very hard on complete emollient therapy. They used some steroids. They didn't overuse them. They got his skin beautifully under control, and his toddler years were fairly quiet. He went to a brilliant nursery, by the way, and they were fantastic because every nappy change they put emollient on. So and then he went to school. And then everything changed again. So his parents say, well, he's not grown out of eczema. They're still there. He's got new areas on his eyelids. That's behind his legs. We're getting stressed. He's scratching all the time. School don't want to put emollients on. They're not interested. There's irritants at school. There's a dusty gym. You see the picture. So this is, we'll ask you a few more questions. That's how he's looking. So main areas are the classic flexural areas, but then we've got this really awkward eyelid area, which is really difficult because when Jack gets grumpy or if he gets tired, he comes back to school and he's always doing this. So he's rubbing his eyes. So what do you think are, and this is just free text. So what we're looking at that situation, what do you think are the 3 most important management strategies? I've left it purposefully slightly open to actually try and get Jack's eczema under control. You might need to type quite quickly. And if you just want to put one important one, it might, in interest of time, it might help. Can you think, reading that case study, what would you do? So great, okay. Good. Oh, it's a word map. Oh, I love these. They're fun, aren't they? So the bigger the text, the more importance is added. These are great fun. Yes, excellent. Okay, got a few more coming in. Yeah. Oh, look at this. I really like this one. Any more? We've had 6 very good ones, I have to say. Excellent ones. Lovely. Okay, well, in interest of time, because we want to try and get through all the case studies we can, that is absolutely brilliant. The situation is that Jack has only really had hydrocortisone, maybe a bit of Humavate, and of course, his eczema's just literally got out of control, maybe because of irritants. So yes, lots more moisturizer. We would think of a humectant emollient at school, particularly because to last the school day, and that would help a lot. Definitely a potent topical steroids behind those little knees, just to really get that under control, or more potent steroid. De-stress, yeah, the family are really stressed, and absolutely for his eyelids, I would have no hesitation with starting him with either Elidel or Protopic. I mean, Elidel comes as a cream, it's slightly weaker than Protopic. I may at 6 just start with Elidel and then maybe move up to Protopic. But I probably would keep steroids off his little eyelids and just go for a TCI and hopefully build up to a maintenance. It might be spring as well. There might be pollen in the air. So you might be able to reassure parents that once the pollen's flown away, it might get a lot better. But that's brilliant. Oh, absolutely great. Well done. You did really well. So there we go. So this is what the PCDS say. They have steps in terms of their management. Have a look at their pathway. And then, you know, this is sort of a summary really. And we've said all this morning. So that was really good. So let's try another case study, shall we? Acne. So now we're meeting Jade. So this, I think, again, I'm hoping this will be somebody you will see. So Jade and her mum have seen that, you know, the pharmacist is available to talk about skin, and they've come to see you because Jade has got lots of spots and she's constantly picking her spots and fiddling, and she's got an array of creams, but actually you're the very first healthcare professional she's ever seen. So they might see you in passing and ask you, or they may ask for an appointment with you. I'm not quite sure how it works, but anyway, whatever happens, they're in the surgery and they've come to talk to you about acne. So that's interesting. So as I say, she hasn't seen anyone before and she's just been using a variety of things. So, okay, it's mild, maybe moving to moderate acne. So would you be thinking of prescribing anything, or would you be thinking of recommending any topical treatments over the counter? A bit unfair because we perhaps haven't gone through this in enough detail, but any thought there? Yeah, so we... Great. It's great. Yeah, well done. Great. Okay, that's great. Well, I think you're all right again. So excellent. I think there's definitely more papules. I think you're right, Mr. or Mrs. Duac, sorry. There are a few pustules. I might not dive straight in with Duac. I might just keep that in reserve for the next 8 weeks to see if more pustules form. I think with benzoyl peroxide and adapalene, I think they are good choices. But I think they're more of a majority of comedonal acne, so whiteheads, blackheads, rather than just pustules. So yeah, I think I would go for the lower strength of Epiduo. I wouldn't kind of mess around with OTC. There's been quite a lot. Her acne is expanding, so that's probably what I would go for. But also with advice about possible skin drying. Epiduo isn't quite as drying as benzoyl peroxide alone. And if you did do benzoyl peroxide, remember to start low and build up. But that's really good. Excellent. So when would you review Jade? So you'd give her the Epiduo on prescription, and you would say, give her all advice about skincare, and then you would set a time for review, which would be a good review. Yeah, so we're just getting up and down. Good. 3 more coming in. It's really fun watching it. I love this system. Yeah, no, that's good. I think 2 weeks might be a little soon, but then I think, you know, if she's distressed, I think that's you kind of, your heart's going out, isn't it? And you kind of want to make sure she's okay. I think really you could say 8 weeks, because we generally say for acne, you need to persevere with treatment for at least 2 months to make sure it works. But you might want to see her in 4 weeks just to check compliance. So yeah, but you could with acne safely say 8 weeks. So that's good. So basically, it does get worse. It doesn't respond to Epiduo. And exactly as you said, then we've had a move to Duac because her skin has become more pustular. And she's seen her GP now. So you've been a great help in the start. So you've said, well, go and see the GP, see what your GP says. They've come to see you. And she's now with her mother and her father. And the GPs said, we're going to give you some oral antibiotics and an anti-androgen as an oral contraceptive. So the GPs started her on limacycline and an oral contraceptive, and she is 15, remember. So the family come and collect the prescription and talk to you again. And her father is visibly upset because he basically says, I don't want this. I don't want my daughter to go on the pill. This is a real story, actually. This happened to me. So I love to share this story. And as I say, we're bearing in mind that Jade's 15. Her father, she's an only child. This is a true case story. Father is actually 15 years older than mum. So he's an older dad, a late child, a very, lovely girl, actually. And she really wants to get her acne better. But, her dad's like, my daughter's not going on the pill at 15. So how would I'm hoping this will work out. I don't know if it will this way. I've done a Duffer method. How would you respond to Jade's father? This is a really tricky one. I don't know how you can condense it or whether it's easier to talk it through. Perhaps someone try and type and see if it works up. Because I think you must come across this. I don't know. Is it coming up at all? I probably should have used the other system. Oh, no questions from the audience. This one not working, Helen?
I think I'm trying to think of the question, Julie. That's the case with me.
There we go. Well done. I've got one. That's perfect. Yeah, brilliant. I love this. Yeah, we're using the hormones to treat the cause of the acne. Fantastic. Can you explain your concerns? Yeah, brilliant. Advising the pill has multiple uses. Fantastic. I knew pharmacists would answer this so well. Brilliant. Yeah. Okay, that's really good. Yeah, I think they're all fantastic responses. And I think, what I was trying to say is that maybe with a shorter appointment with a GP and the GP actually doing all the right things, maybe it was the father came out and thought, I don't like this, and so then, as a pharmacist, you play such a fantastic role in helping that situation. Has anybody come across this situation before? Yeah, I mean, I love all your answers. It's recognized and approved for treatments. I just go back. Yeah. So exactly how I did it, and actually, oh, sorry, I clicked marked as answers, and they went away. But yeah, and actually, the lovely end to that story was that actually within the next 8 weeks, it's all right. I'm just trying to not say her real name, Jade. Her acne had almost 80% clear. It was fantastic. She did really well.
Sonia asking, do you use combined oral contraceptives alongside oral limacycline as well? Do you use them routinely together?
Yes, I think if you're adding in limacycline and it's a female, it's always worth trying to add in the oral contraceptives. I mean, I suppose if she wasn't happy, and obviously, if the family weren't happy, you could just try with plain limacycline. But in fact, actually, I think that's what happened with, sorry, I keep on saying her name, with Jade. I think she did do I think I remember now, we did do just limacycline, and then she didn't do so well. And it was the addition of the oral contraceptive that made the difference. And of course, she's not going to necessarily be on an oral contraceptive forever. Within 6 months to 9 months, you could just take that off and see what happens. But she might then, but then it might be better to take off the limacycline and keep on the oral contraception. It would probably be better that way to reduce antibiotic use, but it's a bit of a juggle, really. So again, little summary of acne. I think we've been through that. So now we have rosacea, Gemma. Okay, so have a look about Gemma. What do you think of her? I did this the other day and someone said, oh, well, she won't be doing spinning classes because gyms are closed. I said, no, she's bought one of those pentathlon bike things, and she's doing it with people around the world. So, yeah, so she's, think that's the thing. I think, yeah, so she's got this red face. She's had moderate acne in the past. She hasn't had facial problems since her teenage years. She's a fit lady, but she does like a glass or two of wine in the evening. She's got 3 teenage children. She's a teacher herself, so obviously life is stressful. So what do you think's triggering Gemma's rosacea? Any thoughts here? What have we got? Just typing in, I think, again. Wine, yeah. I think wine's getting quite big. I think I like this one best, this word map thing. Sun, yeah, good, good. Being a teacher. Yeah, that's great. I think you've got all the triggers there very well, and you can see there's quite a lot of triggers there to address. I think stress is coming big, yeah. Stress and wine. I think you mean stress and wine rather than stress the wine. Yeah, that's great. Yeah, very good. All those triggers you could address, I'm sure, very well with good health education messages. So what treatment would you suggest here to start with? I think you can have more than one option on this one. I hope it works. Have a go if you want to do more than one, but if you can only do one, just pick the key one up. Can you just do one, do you think, Helen?
Yeah, I've just done one.
Okay, I just didn't know. I was hoping
to be honest, I didn't try more than one.
Yeah, I thought I did.
Now I've done the go.
Oh, okay, don't worry.
While this is going, Eric was asking about which oral contraceptive would you use specifically?
Well, I think if you look at the Cochrane review, which is oral contraceptives and acne, it's very useful because they've got like a sliding scale of oral contraceptions, which are best, which basically they list them in a descending order of the highest efficacy for anti-androgen, which obviously is your Dianet and your Yasmin, the cyprotelerone acetate ones. I hope I pronounced that right. I get in a real muddle with these oral contraception formulas. And then it goes right the way down to just a progesterone only mini pill. So actually you can select, you can look at the top side of the list and select a list. And sometimes, the Dianet and Yasmin, there's more of a worry with other contraindications perhaps. So I think it's just kind of trying to match the right contraception. And I think generally, so what I'm saying is we always used to say classically you'd have to prescribe Dianet for acne and nothing else when Dianet was the only one around, and then Yasmin came in. But now there's others below. So, so your microgynon and things. I can't remember all the brand names off the top of my head because there are so many. But yes, but if you look at that Cochrane review, if you go onto Cochrane and you just type it in, it's only a page, but it's really, really good because it just gives you that sliding scale. On other acne talks I do actually have a slide of it. And I as I say, I can't really put an extra slide up. But I think if you look at Cochrane, I mean, it's just another good evidence source for you. Again, I think the PCDS talks about it as well, but not in as much detail as Cochrane. So yes, I think you're right. We've just got redness, and I think it would be really useful to try the bromidamide gel, but also remember, the sunscreen with it on combination really. I think you wouldn't use metronidazole, as I say, in the absence of papules and pustules, there's no indication for an antibiotic. But I know people reach for it with rosacea because it's just always there. And laser therapy for work, you probably wouldn't you wouldn't do orals, and you certainly wouldn't use topical steroids. I'm sure you all know topical steroids absolute no in rosacea. And that's why it's really difficult when you get somebody with eczema and rosacea together. And that's another reason why I use immunomodulators if people have facial eczema and also rosacea, because you can use rosacea treatment one side of the day and a TCI for eczema the other side of the day. And it's really difficult, that mixed facial dermatoses. So that was good. So anyway, she returns 8 weeks later, and the prescribed treatment, so we're going to say she did have the brominidide, which hasn't helped her rosacea, and she's actually developing papules and pustules over her cheeks. So what would you suggest now? Great, okay. So 12, a few more. Yeah, that's really good. I think the principle is, the principle is you'd always try and keep, always try and prescribe a topical treatment with a systemic antibiotic. And if you prescribe a topical, you'd make sure it was a non-antibiotic. So that takes out metronidazole gel and all antibiotics. You probably would definitely try a topical, Solantra, before limacycline alone. I think if there was still triggers going on, I think this option is very sensible, because then you're trying to reduce antibiotic use. But if her papules and pustules were quite extensive, then actually it might be worth just starting with both. So I think, again, it would depend on assessment, but it would be between those two. So yeah, that's all really good. So there's again a management summary. Sorry, I keep meaning to change that of 30 to 50. The PCDS says 30. I probably would prefer to go up to 50 myself on the face. But 30 is better, much better than nothing at all, and it should be all year round. And again, it's a 2-month rule for rosacea as well. So again. Okay, so last one is psoriasis. So now we meet John. He's a software engineer, developed psoriasis when he was 18 years old, but initially it was quite mild. And he's really only used emollients in the past, but he's getting married in 6 months and suddenly his psoriasis has flared. And he's actually, when you talk to him about how it affects his life, he has a little girl and you know, she's starting to learn to swim. And he says, I just get so upset, because actually, you know, if I take her swimming, people stare at me and she says, Daddy, what's wrong with your skin? So he suddenly gets quite upset in the appointment and in a way is asking for help and treatment. And I think the key thing is his psoriasis is really undertreated. It's almost like he's let it sit there. He says his partner's not bothered at all by it. And she just sees it as part of him, but he sort of wants some help now. So what would you suggest? Yes, very good. It's quite mesmerizing watching this form. I presume you're all seeing the word shark come as well. Fantastic. Yeah, definitely. We've got to get rid of the scale to get the treatment to work. And I think, you know, you've definitely got to introduce more emollients. I think this would be a patient I would like to use diprosalic one side of the day. And I probably would look at Enstilla foam the other side of the day, possibly the gel, but I think at the moment we're just looking at his body. We're not looking at his scalp at the moment. We would ask about his scalp, but let's say his scalp is fairly okay at the moment. He hasn't developed psoriasis in his scalp. But I think that's a really good treatment plan there. So brilliant, well done. And de-stress, I think it's really important. Again, it's really important to be holistic and ask about stress. So then he does return 8 weeks later and the plaques in his body are responding well, but his scalp has actually now erupted. So he's finding his scalp psoriasis difficult to cope with. So we'll say that he's had his diprosalic has descaled, the instiller foam is working really well as his betamethasone and calcipotriol. And he hasn't had psoriasis on his scalp before and he's shedding onto his clothes. And of course, he's even more stressed because the wedding now is only 4 months away. And, you know, he doesn't want to have scale or his scalp affected when he's getting married. Poor John. So what is the recommended order for managing a thick, scaly scalp? What order would you do it in, or what would you use? So again, we've got, would you start with topical steroids and shampoos, or would you descale first, or would you descale for an hour or overnight, or would you use tar or topical steroids? So have a go at that one. Great. I think we've got a unanimous decision here. There we go. Yeah. Yeah, I think the person who's answered second isn't wrong again, because if it wasn't thick and scaly, you would just use tar and topical steroids. Yeah. And I put tar medicated shampoo. It's a little bit mean, really, thinking that some people don't like the smell of tar. So there is another descaling shampoo, which is actually made by Dermal called Dermax, which is quite a nice alternative if people really don't like tar. So what I was doing with 3 was very similar to 2, but just giving a bit of choice there. Yeah, and as I say, I know the guidance says just use for an hour, but if people can use it overnight, it really does work well, and there's no contraindication to that. I recently did an infographic actually for, well, I didn't do the clever design and drawing bit, I just provided the words, but the Psoriasis Association has done some really nice infographics for patients that you can print out, and I did one on scalp treatments, and that sort of describes it quite well.
Julia, Sabahad says, can ivermectin only be used for 4 months, and can the treatment course be repeated?
Yes, that's a good question. Yeah, I should have said that. Ivermectin generally is said that it's best to use it for up to 4 months. And if it doesn't work, then, you know, just stop using it, because maybe it's just not effective for the patient. But you can repeat the treatment course, but that's why the 4-month thing is there. It's almost saying there's no point carrying on with it. And I think generally it's probably not working because the patient's rosacea is more severe and they maybe need limacycline or even low dose isotretinoin added in, but there is a 4-month thing. So that's great. Thank you very much for asking that question. It's really difficult to get all the details in. So why should John, oh gosh, sorry. This is the questions from before. Oh, hang on. I'm sorry. Oh, God, sorry. I'm not very good at this one. I've just taken away your questions. I'm so sorry. I think
Type them again. Can we type them again?
I'm so sorry. I thought it was the one from before. I got confused. Now, this Mentimeter is just too clever sometimes. I'm so sorry. Deleting your questions before I've seen them. Have a type again. So when do you think you should be considered for a dermatology referral? I mean, basically the question is, should we keep marching on in primary care, or should we get to a point? Yeah, if no response for treatment, yes, you may need biologic. I mean, the options for people with psoriasis, I have to say, are amazing at the moment. I think there are 10 licensed biologics for psoriasis, and I think 8 out of 10 address psoriatic arthritis as well. I looked after a patient quite like John, although he basically was a policeman, and a similar situation, but I looked after him many years ago. And he had terrible psoriasis, and he did try methotrexate. We use it in our practice as well, actually. He basically then went on Humira literally as he became 60. And basically he said his life began at 60 because he literally, within 5 years, his mild arthritis, which wasn't too bad, completely melted away. He said he could walk for miles. His psoriasis melted away. He just had 2 tiny patches on his elbows. And he'd literally been covered since being a child with psoriasis. And it's been phenomenal, really. So I used to meet this patient quite a lot because he lives just down the road from me. I used to often meet him in Sainsbury's, actually. So he used to give me little reports. And then he's moved away now. So I haven't seen him for a while. He's moved to the sea because Neville's, yes, that's right to call him Neville because you don't know him. But he's been on Humira literally now about 8-9 years. So isn't that amazing? And I think, there is, the problem is, it is just the eligibility through NICE, because you generally have to have failed on an immunosuppressant, sometimes had phototherapy. And phototherapy does have a place for psoriasis, but it's not very helpful for the scalp. But the problem is patients can only have a limited number of joules. So let's have a look. If patient has more than 10% of his body, yes, absolutely. That's a PASE score. And that would be with PASE of 10% plus and also a DLQI of 10. That's definite indication. No response, fails to respond. Yeah. Repeated steroid. Yes. You just can't keep going. Topical or sooner. Yes. Yeah. I think that they're all really good. Remember, referrals are really difficult at the moment. In Birmingham, it's a year's waiting list at the moment. Hopefully it will get better. And DLQI, I love the fact you're bringing the DLQI. And I do think, do consider some of those dermatology assessment forms. They're very useful. Fantastic. Yeah, that's great. So there we go. And don't forget to assess comorbidities as well, because certainly if there are more comorbidities, you might consider an earlier referral. Right, I think we're there. I think we've just about done it. We are a little bit over time, but not too over. I think schedule was 12:50 and we said 12:30. So now it's just really a little summary from you. See how you're doing. I don't know how many people. It's quite nice to let's see how you're going. And we can compare this, of course, with what we did before. Yeah, great. Oh, can we do infections, please? Oh. I can carry on and go back to infections if you want, but the thing is I will be running over time. So infections is quite brief, I'm afraid. Oh yes, please, can we do infections? Oh, that's very sweet of you.
Yes, the slides will be made available. People ask about slides. Yes, they'll be available through your Morph platform, so not to worry about that.
Yeah. And as I say, I don't think you can pick them off or share them, but I'm just get a bit paranoid about my my photos and things.
That's fair enough.
And as I say, there is a little typo with that quip because I thought I always put a U after a Q, of course. Great morning. Good.
Perhaps we could combine skin infections with skin lesions. So that's
yes. I mean, if people are really, really keen, it's only 6 slides. I can quickly do it, but I'm also aware that other people might want to go because they've got clinics and patients to see and work to do.
We would like some feedback from the session. I mean, if you were to continue
the session, yes, yeah.
I'm going to ask Gurpreet, can we launch the Mentimeter feedback session?
Go back to me. It might be best to do, yeah. I mean, to be honest, if you go on the PCD website and look up fungal, bacterial and viral infections, everything I was going to tell you is there. And it might be really good. I mean, I have got a good session on skin infections, which also includes infestations. And then I've got another session I do on skin lesions. So I think because we've got to do the we must do the evaluation for Morph, because that's really important.
I think that would be helpful. Did you say, where did you say, did you go to the PCDS again, did you say?
Yes, yeah. No, I'm sorry I missed it out, but I think, you know, it's a new session I've done, and I probably was slightly over ambitious, and I actually thought that COVID was a bit more important. But of course, in 6 months or so, we might not need those COVID slides. So that's good.
Yeah, I mean, honestly, we've covered so much, Julie, this morning. I know that people want more, but I think that's just a measure of the fact that there's another session. Expand on this. But you've done really well at covering the main common things. I don't know how you've managed to do it, and you've skipped through a lot. I mean, I think there's a lot of people who are quite experienced in dermatology in terms of the terminology, and there's so many products out there. I have to go back to basics and think what's in that product, you know, and look it up.
Yes, yeah,
other names and stuff. But I'm going to share my screen to get that Mentimeter.
Oh, the code's not working, I think, because I've got to stop share. Just let me stop share.
Yeah.
There we go. Sorry.
And I'll share my screen.
Yeah, or you should be